example, Mayo Clinic. I remember Mayo Clinic's autoimmune liver disease by Saja and Summerskill were based predominantly on database, which was kept from the very beginning. And many such important information has come out from the MRs. So that I think objectives should be for private hospital. And this is what I this is my personal thought, that should be dedicated research verticals in each private hospital with dedicated space. You will get a DSI recognition for that. And dedicated manpower, who is not doing multiple things. For example, biostatistician, for example, modeling expert, for example, bioinformatics, for example, expert in electronic medical record system, right? And for that specific funding. And we need also a robust clinical trial force to do various clinical trial, depending upon a consultant's right, view, interest, and his research question. And therefore, each private sector, I think, should have at least a 5-year research plan with annual assessment, what they have done, what they have lagged, and what are the gaps. And obviously, I am repeatedly emphasizing on DSI recognition research plan with. Sorry?
Nothing, sir. You can proceed.
Okay. So, and fourthly, I thought creating center of excellence in various individual disciplines in various select hospital, and where EMR can be started and enable investigative initiative research. Therefore, these are the things I have already discussed, that clear time-bound phased approach to improve medical and innovation, which Government of India is focusing. And we can have all private sector join together to centrally create a task force to actually identify local priorities and start PhD programs attaching to yourself in university. The system must recognize this and create budget facility and a culture of research, which I call empowerment of research, and recognize research as a strength, which I can incentives. So, so that's why we the way to move forwards are these same thing which I have put in a practical fashion, that they should be a separate entity than the hospital, not for profit entity, which will get you a DSI recognition. And the study contract should be with investigator, sponsor, hospital, and the institute. And all payments from the private sector or the sponsored trial should come into the this specific account of research account. And once you get DSI recognition, once you have separate entity, you will obviously able to collaborate with other university, and therefore you can increase the network. And another interesting, important thing I have focused that CMEs and conference, particularly on research. And instead of giving review talks, I think specific questions and specific research output. And I'll say, for example, in transplant, we were all leading luminaries today in the world. And if they regularly rotate throughout the private hospital, even the public hospital, and request deliberation on their research achievement, that would be a tremendous incentive to the youngster. And their publications should be archived in each private hospital. There should be research archive accessible to it, because that provides the enthusiasm future plan. Thank you very much. Those are my thoughts.
I think Professor Rila can kickstart the discussion, or should we do it after panel? I think we should.
I think the panel discussion is going to be part of the discussion, really.
Yeah. Sonal, you can start the panel, and then we can discuss all the issues.
Hi, can you see my screen?
Yes.
Great. Thank you so much, Vivek, Ashish, and Ajita for this invitation, the entire AILBS team, and for asking us to moderate the panel with such prestigious participants. Professor Acharya has given an excellent talk, which has actually set the stage very nicely for a larger discussion on the current status of transplantation research in India. So, as we know that, to no one's surprise, India is one of the top 3 transplants in country by the volume of transplants we do, as part of the transplant observatory data that has been released in 2019 and 20. And the skills are widely respected across the world, especially as is envisioned by the number of people who are traveling to India for sort of seeking expert medical care. The data is scarce, and as Professor Acharya has also alluded, there is very minimal collective outcome reporting. So we do have islands of excellence in seas of mediocrity, to sort of paraphrase Shakespeare, I guess. They've published data from select centers there. And just a little PubMed search that we did today. When you look at transplantation in India and the United States, the difference in the number of publications is almost tenfold between the two groups. I just wanted to put the stage together with a collective attempt that we've made with the Indian Liver Transplant Registry, which has been running for the last 18 months, and then use that as a foundation to ask specific questions of each of our panel members. Just to let everybody know that the Indian Liver Transplant Registry was started as a special registry or a special effort by the Liver Transplant Society of India. It went live on August 15, 2019. And since then has accrued data on almost 1,300 liver transplants performed across India, with almost all the major liver transplant centers contributing on a regular basis. So to pick a specific question, we just looked at what this registry, although it is still in a very skeletal form, what data it could provide, say on the effect of COVID and liver transplantation in India. So to just give a background, we had done an earlier retrospective analysis on the number of transplants performed in the 4 years preceding the liver transplant registry. And then we had discovered at the time that about 20% of the transplant activity in India is actually from deceased donors, while 80% is from living donors. When we look at this data from the COVID time, this number is shrunk dramatically because we can see that the DDLT contribution is down to only 6%. When we further break it down in the different parts, between say August 2019 to February 2022 and March 2010 today, that data is even more dramatic. So you can see that the number of DDLTs has been disproportionately affected because of COVID. When we look at one of the heartening things is that there has been no change in the gender distribution. So females have not been particularly disadvantaged any more than they are already from receiving liver transplant during the time of COVID. A similar pattern is seen in the difference of the types of liver failure. So there is no change in the acuity of liver failure during the time of COVID as before the time of COVID. Again, the number of transplants performed for HCCs is slightly more. The number of transplants performed from cadavers is almost 100% during the time of COVID as opposed to before. Again, the type from living donor, for example, we've seen a slightly more male predominance of living donors during the COVID epidemic as compared to the normal time where females predominate typically. Also, we now have a nice spectrum of, say, etiology for why people are transplanted. This is obviously a work in progress, but for the first time, we are coming out with collective data as is required and as a requirement and is sort of a big need. So the key points, I guess, for COVID were that there were substantial decreases in DLD and numbers. There was high pediatric representation. The women especially were not disadvantaged from getting a transplantation. There were more male living donation. And from the data we had, we could not ascertain any impact on immediate post-transplant outcome. Although this is a very tiny start, it's still a start in terms of collective outcomes reporting. So based on The first question is probably to Prof. Acharya is, I think you've already answered the first question on how the private sector can contribute. But in research methodology, as you correctly said, methodology training starts at medical school, not just when one becomes a primary professional. So what do you think, or what support is available for professionals in training or mid-career, for example, young faculty at this time?
Well, Sonal, but this is not difficult at all, because the research methodology online courses are available. Even you can organize 2 days research methodology courses in each of your hospital to train the training persons and to provide all the mid-career support. This is not at all difficult at all. And therefore, I suggested one of the things that each institute should have a research division with distinctly a bioinformatic expert and biostatistician and expert in modeling who are good, and epidemiologist as well, in providing in-house regular training system. In fact, I remember after retiring, when I went to Odisha in KIMS, I started this actually and created a distinct division of biostatistics. That is a private institute, and started training the faculty with this, which can be done. Sure. And the next you have written that demolishing academic silos, how can academic hospital and research center? I suggested that during my talk. And in fact, you can clear PhDs much more effectively if you have DSI recognition, but there are steps and there are legal systems which you have to follow.
Sure. I'll just take one step back, sir, about the training part, because at this time we are looking to start transplant fellowships at a national level, supported by professional bodies. How would you suggest that we incorporate methodology training for young professionals as part of their training fellowships?
You yourself will realize, Sonal, that most of the fellows which you take, they're interested in learning the technology rather than cracking the problem. And that is a major focus, and that is also a major focus for the trainers. And therefore, I called it empowerment research and change in culture and thinking, which is the first step before you raise even this question. If you establish that in your training program, that they have to generate research questions themselves from their observations, and the ability to design research, if they are not able to design themselves, then you need hands-on training. It cannot be just trained theoretically. So you have to design with the help of experts and make them see what are the actually flaws in designing research methodology based on the research questions they have generated. And that will go for miles. That will become a very practical approach, actually train your fellows, and that will increase the capability buildings in the research. If you want it seriously in a private sector, in transplant sector, that's the best way where you can answer many things.
Sure. The question on the silos was slightly differently positioned, sir, because as you pointed out, we lead in engineering and scientific publications. We've made a substantial gain there, and we have excellent centers which are of world repute. For example, the IITs, the Indian Institute of Science, and many such more, which are doing world-class research. Some of it is related to healthcare, but they work in silos that are separate from other institutes of national importance, such as the All India Institute. So why do we not have joint MD PhD programs, say, between the All India Institute and, say, the Institute of Technology or the Institute of Science?
That's excellent thing. But first thing, you have to break this barrier between private and the academic public sector institute. I believe Dr. Ela can be a visiting professor at All India Institute or PGI Chandigarh and train surgical gastroenterology and help in transplant, or Abhisoyan or Suhas or Vivek, anybody. So we have to break that. We are unable to break that. We are moving in parallel.
Sure.
And that is a system problem which need to be lobbied. Advocacy group, that's why you need to break this and think this thinking pattern, actually.
Sure. I mean, I guess the point you've made also is that the silos are not just public and private. The silos exist even between, say, well-meaning government hospitals and public institutions. Could potentially work together, because there's nothing stopping an AIIMS working with an IIT, for example.
That's correct.
Prof, just to carry on from that, because you have experience of working across different systems across the world, and clearly there are learnings from all of those systems. And from the NHS, we did learn this rigorous system of using research starting from, say, audit in clinical practice. I think what would be the best way that, say, transplanters could look to that to incorporate research into daily practice?
Yeah, there's a statement that Professor Acharya made. I quite like that. He said, research has to be an essential component of healthcare. I think that's if we all understand that it has to be a component of healthcare, then it's possible for all of us to incorporate that as part of our daily work. He said that even the trainees have to be looking at problems and finding a solution. Unfortunately, in the private sector, our priorities are completely different. The priorities in the private sector is predominantly, really, a lot of private sectors are struggling. Commercial is the priority. There is absolutely no lack of incentive for the private sector to really invest in research. Now, there is a huge possibility in India. I've just moved out into the private sector in the private education side of things, which is a deemed to be university, and I've learned a lot out of how they function. Now, actually, the government has made it necessary for the private colleges to have research as the component of their education, whether it's medical education or engineering education. So they have this ranking system and for somebody to exist as a deemed to be university or a private university, they have to have a huge amount of research. But what I see is we are looking to beat the system rather than actually put the investment into actually fulfilling their requirements. I mean, I see unbelievable amount of publications in journals which have no impact factor, paid publications. When Professor Acharya put the number as whatever it was, 100,000 publications from India, a lot of this, unfortunately, is also going on in the engineering side. A lot of these publications are worthless, really. Just looking at numbers is not enough to say that we are going there. So it needs to be really, there has to be a stick, really. There has to be, it needs to be part of it. I mean, you asked about the UK. I worked for 25 years in the UK. I went there with absolutely no experience in research. I worked as a middle grade registrar in many hospitals. Even there, I really struggled to publish as an outsider going into the UK. It was very difficult to get good jobs where the consultants were interested in publications. I think things have changed over the years. And when I went to King's is when I started publishing. King's, it was a teaching hospital. It still is a teaching hospital. And there was a huge clinical material. I wouldn't say credit myself as having done well because of my abilities as a researcher. I had good supervisors. So to become a consultant, you needed certain amount of publication, but only when really I got into the system, when I was really hoping for a personal chair to become a professor, I realized you really have to do serious research, which is really when, after becoming a consultant, is when I learned about basic science research. We went into really gene therapy and some animal models. Now, so the UK system has actually incorporated, I mean, my daughter's working in UK now, and I know how much she works hard to get some publications in order to get the next job or get into the system to become a surgeon. And the UK really has had this for many, many years. I mean, I was just looking at it. I mean, if you want to know the discovery of islet cells in insulin, it was Banting and Best. Best was a medical student. Vitamin C as a treatment for scurvy was discovered by a medical student. So this actually shows us that it has to be an essential component of the healthcare system. And if we have that, and forget this idea, I mean, who will you appoint as your colleague in your hospital? You want to appoint somebody who's able, good clinician, who's technically outstanding, who will do transplants without complications, and actually improve your results and services. That's what we are focusing on. We are actually not focusing, there is no value added to research in this country. So that is the main problem. And the private sectors are extremely successful because they have got extremely good clinicians there, but they are not actually valuing research among the clinicians that they are appointing. Unless we incorporate ranking system and incorporate research into the ranking system of private institutions, the private sector is not going to investigate. You talked about a collaboration with IIT. So that's one of the problems. I mean, I've been having trouble with really, we now have a lab, a basic science and an animal lab. And the funding is a big problem. So I've had to put in a lot of really money that we earned from the private side and then put that in at least to get started, because in the private sector, unless you have a track record, you cannot attract funding. But now we have got collaborations. You said about IIT. I've got 2 researchers from IIT who's working with us, 2 researchers from Anna University who's working with us, and 2 postdocs who are appointed by us are all from really Anna University and IIT. And they're extremely bright. There is absolutely no shortage of bright young researchers in our country. It's all about the funding and convincing the private sector that it is important and that it has to be part of the healthcare system that we have in this country. Otherwise, it's not going to change.
Thank you. So, I mean, just to sort of put you on the spot there, for if there were 3 positives that you could say about doing research in India, what would they be?
3 positives.
Yeah.
I think in the international, we are all in the transplant field. In the international arena, if we want to be outstanding or recognized as outstanding, we need to show what we are doing as publication. It's not just talking about it. Otherwise, there is no way we will have reputation.
Sure.
The first positive is, I think Professor Acharya repeatedly said that we are trying to learn technology rather than really finding out what the problems are and solution to it. And unless we go into the system of finding out, and we are ahead of the game. I liked yesterday's program on really laparoscopic liver resection. I don't think we'll be any inferior to anywhere in the world, really, in terms of laparoscopic donor hepatectomy or laparoscopic liver resection. We can lead the world in it. But why are we not leading the world in it? I mean, we have the potential to do the number much more than anyone else. Unless we do it and publish it, we won't be. I mean, if you look at the publications that have so far come out and really the leaders in the field, I think we can beat their number in no time. I'm sure they recognize it as well. So it's a contribution that we make to the science that should be our really incentive to do this well.
Thank you. The next question is to Prof. Theeman. I think that, again, taking a step back about, I mean, basically about 2 things. One was about deciding national priorities for transplant research. I guess to direct funding towards particular questions, we have to decide as a country what we are going to focus on. How should one do that, from a public institution point of view? And secondly is about training. We've talked a lot about that. And how can we put together a clinician scientist training pathway? We've talked about the MD, PhD between different institutions, but what about the same institution? How do we do that? And of course, everybody has talked about funding options for research. So, Prof. Theeman, if you could just enlighten us on what are the options available to us right now from a funding perspective. Is Prof. Theeman there?
Dr. Theeman was there. I think he's logged out now. I don't see him.
Yeah, he's not there. So, I mean, to follow on that question, this was a paper published from the Canada Transplant Research Consortium on setting research priorities. And they had a group of stakeholders together. And these were the 14 priorities that were identified in Canada about what research in transplantation should focus on as a country. And perhaps that is sort of a good start for us to kind of look at these some questions. I'm just going to stop sharing my screen, and there's a small survey for the audience here. Can the administrator please administer that? So this is for all the participants right now. Could you please select whether you are a trainee or a consultant? Okay. So there are no consultants in the audience. Okay. The second question is, can you please go to question number 2? Okay, 33%. Are you from a surgical or a non-surgical specialty? Okay, we're very evenly divided. Surgeons are winning. All right. So basically, surgeons by 3:1. And the third question, and I've just paraphrased perhaps 5 or 6 of the questions from the Canadian list. If one could select, if all of you could select 3 out of these outcomes, please, any 3 of these outcomes, about what should be the national priorities for India as a country. The panelists can vote as well. So please feel free to do that.
I don't think we can access that actually. I can't access that.
I was told that everybody on this could.
I think that's a technical glitch here, Sonal. I think the panelists won't be able to poll the.
Well, that's a shame because it would have been nice to get some options here. So, okay, so I guess that increasing numbers and prevention of end organ disease is sort of a priority for most people who have voted. So yeah, I guess this was basically the point here. Perhaps setting priorities and seeing what people in this audience thought would be a priority would be great. The next, can I get back to sharing my screen? Okay. Right. So unfortunately, we won't be able to discuss funding options. Prof. Acharya had mentioned them briefly, as had Dr. Prof. Rela. But the next question is to Professor Mathur, because currently the evidence in the development of an organ allocation system is actually quite critical about how we should allocate organs based on severity and local disease types. The first question is, how has audit and research of local practice changed policy for the ZTCC in his long time there? Professor Mathur.
Can I share my screen if it's possible? Otherwise, I'll keep at random.
I'll stop by sharing. Please share.
There is a problem, guys. I've lost everything.
Who lost? Mohammed?
Yeah, I can't see anything.
Oh, have I blocked you?
No, I've lost everything on the screen, I said. Go ahead. Can you just speak, Professor Mathur? That'd be great.
Dr. Rela, you are visible. Can you speak? Because we can hear you properly.
Okay, I'm visible, but yeah, I can't see anybody else. And maybe a problem with me. I don't know.
Okay.
Prof, can you see my screen now?
I'm back. I'm back.
Okay, so I think it's Prof. Mathur, would it be possible to just perhaps
Yeah,
tell
yeah.
us about
Yeah,
this?
I will do. See, the basic thing is that what you are talking about, the evidence-based development of organ. If you look at internationally, yes, the allocation system has progressed with the evidence, which is not absolute, it is controversial. Let me put it this way. Today, MELD score, a MELD sodium is supposed to be the best system. There are enough articles by the authorities criticizing MELD and also showing that CTP score is as good as the MELD score as far as the weightless model is. There are enough evidence. And we have so many exceptions in the MELD score that we have a problem here. Anyway, without criticizing them, let me put it what we did and how the evidence is produced. Okay, in the allocation. I'll tell you, when we started in 1999, first guidelines which were prepared in Maharashtra, they were based on the UNOP system of status 1, 2, 3, 4. In 2010, we changed it to and based it on UK system and European system, which was predominantly based on the chronology and the super urgent category. So we divided it into a super urgent category and an elective category. And in the elective, it was blood group and the chronology based distribution. Now coming to the evidence, what happened that when multiple centers started doing transplant and organ donation improved, the sharing started, and the criticism came that the chronology is not good. Now let's put it, what is the advantage of the chronology? Main advantage has been it is easy to manage, difficult to manipulate, which is very important, and it's most transparent and fair to the patient, not to the center always. Disadvantage, which is claimed to be, it ignores the disease severity and perhaps increases the weightlessness. Now, to address this issue, because I can't share the slide, we looked into the data of 52 patients. Now, it is not the analysis done by me. It was done by a DMPG at KEM Hospital. So there were no interest for him because they were KEM were not doing any transplant. And they looked at it, whether the chronology and the MELD score. We had the MELD at the beginning and MELD at this thing. We found that the patient with the highest MELD weighted least, and the patient with the lowest MELD weighted maximum period of time. So in spite of the distribution being done on chronology basis, it actually neutralized the effect of the chronology, and the patient with the higher MELD got the organ faster. Now, why did it happen? Because we had a clause in our chronology that if a hospital feels that they have got a sicker patient, then they can give it, provided they are communicating with the ZPCC expert committee and informing them why they are breaking the chronology. And that gives the leverage to use the organ for a sicker patient when it is required. Okay, so that was one evidence which got created. It is not the chronology which is always bad. The second thing was, there was a time when people were not ready to use the organs which were classified as a marginal extended criteria, particularly patients over 60 years of age. And that is a donor above 60 years old. And then we looked at the data of 5 years when we analyzed, we found that outcome in this group, which are marginal donor organs were transplanted, where almost 70% were above 60 years. And some of them, in fact, 1/3 were above 70 years old. Their survival was almost 70%. So that again shows, that gave the confidence to the transplant team to accept the marginal organs. And that's what is happening today. So that is the effect of the audit which we did on the basis of what the whatever system which we have been following.
Sure.
Yeah.
I think that unfortunately we are a little short of time right now because there were definitely two more pressing questions. But it is it is getting to be a little longer than.
As far as the compliance is concerned, that's what it is there. See that until 2016, at our place also in Mumbai, compliance was hardly anything as far as the follow-up is concerned. There were several threatening letters were written through the government, through the agency and everything, nothing worked. But after I took over in 2016, we have, I'm very proud to say that from 2014 onwards, till date, we have follow-up data of all transplanted patients. I'm talking about the DDLT and kidney transplant and the heart transplant patients, only diseased organ transplanted patients.
Sure.
So we have their 30-day mortality, 90-day mortality, 6 months mortality, 1 year mortality, and then survival till date. That's what we could achieve, and that is only because of the persuasion and making everybody understand that this data will not be used for any wrong reason.
Sure.
So it is all data where the hospitals or the programs names are never displayed when the results are shown.
Now that's excellent because those are two very critical points. One is winning the confidence of the people who are sharing their data with you. And the second is you've given two very specific examples of how an audit of practice has impacted organ allocation in a particular state. So thank you very much for that part. Towards the end, there are a few common questions, and I'll just use the opportunity to summarize and perhaps take questions from the panelists, for the panelists actually, if anybody has that. So these are a few more thoughts which we have not really covered specifically, but happy to discuss. Are there any questions right now for any of the panelists?
So, if not, can I make a comment? Because the research has been my forte for whenever I was in KEM, even when I came into the private sector. Yes, I agree with Mohammed Rela that in the private sector, money is the primary aim. As far as the administrators are concerned. Unless the administrator happens to be owner, means he himself, like Mohammed is owner of his own institute, he can do the things the way he wants. But when somebody else is the owner, the corporate group, they only count the money. They don't look at your what is the research potential or whether you're invited to 10 conferences or not, if it doesn't turn out to be into a number of patients and the income. Okay. But where the apathy is you don't have to do all the time molecular based research. If you can do it, that's an excellent thing. I always like the people to do it. But even the clinical research, which is basically maintenance of your data and analyzing it, people are not doing that. That's the whole thing. So it's not that the people can't do it. It is the programs are not encouraging their juniors to do that thing. If they give them problem, okay, analyze our data from this date to this date for this particular thing, they will get the answers. It is simple thing that we today still quote a 1990 article published in Tropical Gastroenterology that how many patients die every year of liver failure to 2 lakhs. Okay, that data has not remained unchallenged. Why? We have so many hepatologists across the country of repute who have worked in the big institutions and could not produce the data on that. What is the mortality in these patients? We don't have a collective answer to that. Everybody keeps on quoting. Noto quotes something else. Koi kehta 1.5, koi kehta 50,000, koi kehta 2 lakhs rupees. So what 2 lakhs patients? So why this problem is there?
No, actually, sir, I would like to make a comment on that because, in fact, Kaushal was supposed to talk on that part. One is about interoperability of different registries. Because, for example, INASL maintains a NASH registry or an alcoholic ALD registry. We maintain a transplant registry. So is there any way in which these registries could talk to each other, for example? Because there would probably be a fairly large overlap between people with advanced NASH who would then come onto transplantation. So interoperability in a country that has made UPI and Aadhaar, it should not be difficult for us to do that, to be honest. So I think that this is this is probably one of the things that we could put together. Of course, much has been done, much needs to be done. And if there are no other questions, I'd like to thank all the panelists for their valuable time and their comments.
Sonal,
Yeah.
Prof. Rela, thank you so much. I would like to suggest one thing, that in LTSI, should we have one-day program of research methodology for even for us? Means uh, I'm clueless because we have never done basic science or clinical science research with multicentric trials and everything. I think this is one thing we should do, that at least start by learning the research methodology. That's my suggestion.
No, I think that's an excellent suggestion. There's a general body tomorrow, so there's probably a good opportunity for us to discuss it, in an open forum. I have no, it's an excellent plan.
Okay, thank you, Sonal, and thank you all the chairpersons. We can move to the next session.
Thank you.
Thank you. We can move to the next session on transplant oncology. And the first session, part of the session is expanding candidacy and improving outcomes. I would like to invite the chairpersons, Albert Chan. Albert Chan, he's the Deputy Director of Liver Transplant Center at Queen Mary Hospital, Hong Kong. He's a Clinical Associate Professor and Honorary Consultant in the Division of Hepatobiliary Pancreatic Surgery and Liver Transplantation at Queen Mary Hospital, University of Hong Kong. I would like to invite Dr. Ravi Mohanka, who is the Chief Surgeon and Head of Department of Liver Transplant and HPB Surgery at Global Hospitals, Mumbai. Dr. Vinod Raina, who is a known face in the field of medical oncology, and who is the Chairman of Medical Oncology at Fortis Memorial Research Institute, Gurugram. I have a Dr. Ashu Abhishek, who is a Senior Consultant in the Department of Radiation Oncology at Fortis Hospital, Gurgaon. And unfortunately, Dr. Sanjay Govil won't be able to attend the meeting. Albert, you can.
Yes. Okay, can you hear me now?
Yeah.
Oh, so thank you, Dr. Vivek and Dr. Singha for the invitation as the chairperson for this session on transplant oncology. And it's certainly my pleasure and honor to invite the first speaker, Professor Shimu Shah, who is the James and Catherine O. Endowed Chair in Liver Transplantation and Professor and Chief of Solid Organ Transplantation at the University of Cincinnati College of Medicine. And his topic today will be on downstaging and managing HCC beyond conventional criteria for liver transplantation. Professor Shah, please.
Thank you, Albert. Let me just work on sharing my screen. Thank you. I hope you can see my screen there. Albert, you can see my screen.
Yep.
Great. Great. Well, thank you for the opportunity to give this talk. And I thank the society members and the leadership of the Congress. This is a great opportunity and should be a great day as we talk about transplant oncology. I was asked to talk about downstaging and management of HCC beyond traditional criteria. It's important to review what are all our options when we see a patient with HCC. And I think at the top of the heap, we see liver transplantation, but there are now many options in our arsenal. And it's important that we understand what is the rationale and the efficacy of all the 8 or 9 different options that we have in our toolbox And today, I'm not going to talk about resection, but we are going to essentially touch on all these other avenues as a way to downstage and bridge people to transplantation. Currently, when someone has an aggressive HCC, a large tumor, who you see matters. And that matters in terms of what specialty you are, where the center is, whether it's part of the Eastern world or the Western world. The management greatly differs, and as does the protocols. When you have a patient like this with massive ascites, a ruptured umbilical hernia, and a tumor that's about to be intubated, there is really only one option, and that's a transplant. But many of us would take this on in different forms, especially when the patient is decompensated. So why liver transplant? Just to review here, cirrhosis is commonly the underlying condition in patients with HCC. For multifocal disease, if the tumor is unresectable, if there's an inadequate liver remnant, if you are planning a resection, recurrence is much lower with transplant versus resection. And if you have a solitary lesion, which I'm not going to touch on today, in a compensated cirrhotic, you could argue that it's the best cancer operation in terms of results. We all know that you have the maximal local regional recurrence when the liver is out and you have a clamp on the vena cava, and hence a new liver would go in versus other modalities that we have in our arsenal. The Milan criteria we all know well: 1 tumor less than 5 centimeters or 3 tumors less than 3. With excellent results over 20 years ago. And then we have the UCSF criteria as well, with the total tumor volume less than 8 centimeters, 1 tumor 6.5 or 3 less than 4.5, with excellent results from the UCSF group. So when we think about the concept of downstaging, it's important that we understand exactly what we're talking about. We're talking about tumor burden and understanding the size and the number, recognizing that it's outside of normal criteria or expanded criteria, but understanding more about the tumor biology, tumor markers, what's the response going to be. And local regional therapy traditionally has been given in all different aspects throughout the course of trying to downstage the patients with the ultimate goal to get to liver transplantation. Our indications for transplant are increasing more and more. And in 1996, we had the Milan criteria, but now in the eastern part of the world, we're getting more and more criteria where essentially I'm not sure that someone is not a candidate when they enter our clinic. And we are essentially trying to downstage everyone we can in order to get them to transplantation, and the indications are ever expanding. We have multiple modal treatment, whether it's done by surgeons, interventional radiologists, endoscopists, to bridge or to downstage these tumors. Let's talk about the different types. So ablation can be done either by laparoscopic performance or by interventional radiology. At our center, primarily the interventional radiologists do the bulk of it. If we do it under CT or ultrasound guidance, it works well for smaller tumors. TACE or Y90 is our current approach with arterial therapy directly to the tumor. We tend to do much more Y90 in Cincinnati compared to TACE, a much larger tumor kill. We can see a couple of cases here. Here's a 57-year-old with biopsy-proven HCC, a large 5-centimeter tumor in the right lobe that has enhancing tumor thrombus. You can see the liver numbers are essentially normal. The tumor is seen there in the posterior right lobe on the arterial and the venous phase. And you can see as well that there's tumor thrombus going into the posterior branch of the right portal vein. This is before treatment. When we take a look, we also have multifocal tumor, both in the left lobe now as well. When we take a look here, the tumor enhances, and then when we undergo TACE, we can see that there's blush and direct venous involvement and arterial involvement of the tumor, and it's very effective. We can see the direct the tumor treatment as well as direct branches that are completely embolized in the left lobe and the right lobe. And you see the before films and the after films. The tumor is killed over the course of about 6 months to a year. So 1 year after the TACE, the patient had no more treatments and the patient was successfully transplanted. This case is the patient's doing well now 6 years after transplant. So that's a normal routine case, but one with vascular invasion, which many would consider not approaching with transplant. SBRT, or stereotactic total body radiation, is becoming also a more widely used modality. We also use photons and have a proton beam treatment center at our place. has ablative doses, has tumor kill death, and large gray fractions that are localized to the tumor. The main advantages is it's non-invasive. There's no pain. The patient has to come to the center every other day for about a week or 2 weeks. It can be used in treatment for patients that have portal vein thrombosis, aggressive shunting. Some disadvantages include that it may not be localized, and especially if other organs are nearby. Here's an example of what the centers look like, very innovative and high tech, but the localization is very promising. And when you compare it to conventional radiation therapy, you can see that the focus on the tumor is excellent. The results that we have seen, and here's an example in a cirrhotic liver, how you can really localize and avoid the major vessels and focus on the tumor. The proton data, and this slide is now actually kind of old though, is very, very good. And it just depends on what part of the world you're in and whether this is available. But in a total of 1,500 patients, these results are parallel to results using TACE and Y90. And except for the fact that the patient has to come to the center for multiple sessions, can work very well. And many centers use this as their primary modality. And when you compare this to traditional downstaging tumors within the Milan criteria, you can see the downstaging success of 50 to 70% is comparable whether you use SBRT, TACE, or Y90. So I think all the different treatments really depends on your center preference. And to give you an idea of this, here's another example of a patient that presented with 11 tumors, biopsy proven, didn't have any evidence of microvascular invasion, an AFP of 200. And then as we looked in closer, did have portal vein invasion and portal vein thrombosis and a large tumor that was about 12 centimeters. He underwent Y90 to both lobes in the same session and then was placed on sorafenib. This case is about 5 years old now. And if you look at his scans, you could see multiple tumors throughout the liver. And then had the Y90 treatment. About a year later, the tumors essentially became cystic and looked necrotic. He was tolerating sorafenib for close to a year. We went ahead and listed him for transplant. And when I transplanted him, there was no viable cancer found and the tumor was completely dead. Hard to explain some of these cases in the sense of some that respond and some that don't. So just to review here, the role of downstaging, I think at our center, we categorize them at low risk and high risk. And in pretty much all the high risk cases, we are attempting to downstage, provided they don't have metastatic disease. If they have local disease in the liver, regardless of the number of tumors or vascular invasion, we are attempting to downstage them with one of the modalities to get them to transplant. When we looked at our data over the last 5 to 7 years, 28.7% made it to transplant. So 1 in 4 patients makes it to transplant, and we found that our HCC recurrence and our OLT survival was equivalent whether they were low risk or high risk. Just to break down this data a little bit more, as you can see, the low risk group on the left side, half of them made it to transplant with only a 2% HCC recurrence and a 2% mortality, which I think is what we're seeing, many centers are seeing around the world. Excellent results. On the high risk side, not as good, but actually non-significant compared to the low risk group. 20% made it to transplant, 5% recurred, 10% died. All the recurrences did pass away. So certainly a higher risk of recurrence in the high risk group. I think if you can get them there, you transplant them. Systemic options are becoming more and more common and something that we should talk about in the history. In 2007, we had the SHARP trial with sorafenib. And this slide really outlines the different agents that we've used over the years. And now the agents we are using primarily or thinking about using is immunotherapy. We all know about the Atezo-Bev trial, the New England Journal of Medicine last year, and more agents are coming out as modalities of immunotherapy at checkpoint inhibitors looking at treating HCC. These are the 4 trials that have been out, 2 that are still ongoing recruitment, Embrave and Keynote. We don't have the results on the Keynote trial yet. You can see that the overall survival is not good. These are in patients that are not necessarily surgical candidates, Child's P class A, but Barcelona tumors B and C, but ECOG scores of 0 and 1. So good patients, but more in the metastatic and non-resectable category. When we think about what are our options for treating these tumors, I think we have to think globally and looking at the different strategies, whether it's adoptive immunotherapy, whether it's cytokine or immunocheckpoints, whether it's looking at non-immunological strategies with oncolytic viruses. All of these treatment strategies will be in our arsenal over the next decade. And it's important that we as surgeons and medical oncologists and hepatologists think about these different options into what works best. At our own center, we are looking at starting a trial of patients that have HCC and cirrhosis that are listed for transplant. We are going to do 6 months of immunotherapy and then followed by liver-directed therapy with a 3-month washout before we proceed to transplant. This is highly controversial. There's not many reports of doing transplant after immunotherapy. We have done a couple, but the importance here is to determine, is there safety in transplant after patients have been on immunotherapy with an appropriate washout? And I think this is a very important question that we need to answer as a community. Here's an example of another downstage HCC case. She was resected in 2015, lost a follow-up, moved to my part of the country, and presented to me with bilateral recurrent disease in 2018 and 19. Over the course of 2 years, we gave her multiple treatments of TACE and Y90. During one of the treatments, her HCC even ruptured peritoneally. Here are some of her scans in 2019 when she presented. You can see multiple tumors throughout the liver. She had a total of about 10 tumors. Healthy woman, not cirrhotic, as you can see. We treated her with aggressive rounds of Y90 and TACE over the course of the ensuing months and attempted to just chip away and treating the tumors. In April of 2020, we started to get some regression, but some tumors were growing, and therefore we started her on nivolumab and lenvatinib for 4 months. So she got aggressive immunotherapy. She had CERT for 3 rounds, TACE for 2 rounds, even a round of microwave ablation, all done by our interventional radiologist. But we started having biliary necrosis, which is why we moved over to then systemic therapy over the summer of 2020. And in August, here is her scan. You can see the tumors are present, but they look a little bit different, likely from just repeated Y90 to the tumor. After a 3-month washout of the immunotherapy, she ended up having about 9 lesions in the tumor. I transplanted her in October, so only about a 5-month follow-up as I'm presenting this case, but only 1 tumor was viable. No evidence of lymphovascular invasion. She has done well, but with a short-term follow-up, and she's our 2nd case of transplantation after being on immunotherapy. So I think I discussed here in summary, there's many immunomodulatory approaches. I think this is the future of our field when it comes to HCC. I think we need to understand the multidisciplinary chemotherapy. What is the role of checkpoint inhibitors? Is there a role for cancer vaccines? And then we have our normal liver-directed therapies with radiofrequency ablation, Y90 or TACE. I think that this is a multidisciplinary approach, different options for every patient. There's every center should have a protocol and think about how they're going to approach downstaging, but there is a role for everyone on your team to be a part of these treatments. The goal when you have a multifocal tumors is to get them to transplantation. Thank you very much.
Thank you, Prof. Shah. So may I first actually ask the question, for these patients who are successfully downstaged and listed, do they get bonus point for the transplantation?
Yes, so in the US, they have to wait 6 months, mandatory UNOS waiting time because they're a tumor patient, and then they get exception points and do jump the list and then wait after that.
Right. So, right. And the new trial in immunotherapy seems quite exciting. Is there any particular, I mean, there is actually a variety of choices. Is there a particular reason why you chose durvalumab, but not the other agents on the market at the moment?
We went with the company that was willing to fund the trial.
Right, great.
The companies are very fearful about adverse events after immunotherapy. And so I think it's a tricky situation in terms of trying to get a trial funded. And we just heard the research talk in the previous hour. There have been some reports of adverse outcomes, including a couple of deaths, and maybe some people on the panel have had similar experiences with immunotherapy. We haven't had that yet. Again, our numbers are low. We've also been giving immunotherapy for recurrences post-transplant and haven't had any major issues yet, but certainly fearful about what the effects are. So I do think it needs to be studied.
So any change in the immunosuppression for these patients in this trial, or just go by the standard routine?
We haven't done anything different. We do TAC and cell
just keep the
dual therapy.
Right, great. Thank you very much. So do we have any?
Albert,
Yes.
I have a question for Shimul. Shimul, excellent talk. Do you still consider somebody on downstage and while on the waiting list for transplant if there's a disease progression while on waiting list without any extrahepatic disease?
So I didn't talk about that aspect, but if they have disease progression while on the waiting list, we don't transplant them. We, again, try to continue to do liver-directed therapy and try to chip away at the tumor as much as we can in order to get them to a stability of disease. In the US, they have to have an AFP less than 400 and be within the Milan criteria to get the exception points that Albert was talking about. But if they do progress, I think that's a bad prognostic factor. I can't say that we haven't done it, but I think there's a higher rate of recurrence in those situations.
Shimul, one small question. What's your take on living donor liver transplant programs for such patients who are
100% behind it.
Should we wait for 6 months or?
No, I think we've talked about this in the US as well for colorectal cancer. I think that if a donor steps forward and wants to donate, we should proceed. There's been some talk about ethics behind this. I think it's totally reasonable to do. No different than proceeding with a transplant for the patient. The outcomes are excellent, whether they're downstage or not, as you can see from not only at our center, but at many other centers. Even in the downstage patients, the recurrence rates are still relatively low.
Right, great. Thank you very much, Professor Shah. So we move on to the next presentation. Dr. Singer?
I have a question, quick one. So
Yes.
when you're looking at response, is it only imaging, or if you see a similar picture on imaging, but a good response to AFP or DCP, would you still consider it as response?
So it's a combination of the AFP and the imaging. If the AFP is going up, that's a very bad sign. And that means, and if you don't see it in the imaging in the liver, it's very possible then that you have metastatic disease. So then you have to start looking elsewhere. But I would worry about the AFP.
Thank you.
Thank you.
Do we have Dr. Soin online?
No, can't see him in the list.
Dr. Monka, he's just logging in, so he'll be there shortly.
Sure. So so should we wait for him or switch the talks around?
Why don't we go to our next talk?
We can have Dr. Charles Rosen. He's online, so okay. Dr. Charles Rosen, he needs no introduction. He's a professor of surgery in Division of Transplantation Surgery at Mayo Clinic, Rochester. He's the one who's pioneered the Mayo protocol for liver transplant for cholangiocarcinoma. Dr. Rosen.
Good morning, everybody. It's good morning for me. I think it's a good afternoon for you, and I'm just delighted to participate in this conference. My only regret is that we can't be with each other in person and enjoy discussions before and afterwards. But in the next 10 minutes, I'll talk about our experience with liver transplantation for hilar cholangiocarcinoma and essentially try and define the role of this treatment. I don't have any disclosures. And as I begin, though, I think we should also look at some of the confounding issues about transplantation for malignancy, particularly in the US. We all know that there's a donor organ shortage, and that when we're doing transplantation with deceased donors and living donors as well, that we have to exercise appropriate stewardship, prioritization, and be responsible for our living donors, meaning that there would be a reasonable chance for success with transplantation. In general, we use about 50% 5-year survival as a reasonable chance for success. In the United States and in many other countries, there are performance metrics for which we're accountable. And in the United States, we have a lot of government and payer oversight about our performance. We also have to look at the outcome in general. not just because of the malignancy, but because these patients oftentimes have underlying liver disease that also can affect their outcome. And their malignancies can progress while they're waiting for transplantation, or at least the C-stone or transplantation. Shifting to cholangiocarcinoma, all of us are pretty much familiar with the old data from the Cincinnati Transplant Tumor Registry of 207 patients transplanted between 68 and 97, where the 5-year survival was about 20%, which is far below what we would consider a reasonable chance for success. And when I was a fellow in the late 1980s and early 1990s, cholangiocarcinoma became a contraindication for transplantation. Even so, there were some patients with primary sclerosing cholangitis who were found to have incidental cholangiocarcinoma on the explanted livers. And 3 series come to mind that are shown here, but all show absolutely terrible results with outcome if an incidental cholangiocarcinoma was detected in the explanted liver. And for that reason, we centered our efforts on trying to avoid transplantation for these patients. However, Greg Gores, Lynn Gunderson, and radiation therapy, and many of our other colleagues at Mayo Clinic developed a protocol in 1993 designed to treat patients with cholangiocarcinoma, either arising in primary sclerosing cholangitis or arising de novo, and was deemed unresectable. The patient care protocol involves careful patient selection, external beam radiotherapy with chemosensitization, intraluminal brachytherapy, a subsequent exploration for staging prior to transplantation, and then liver transplantation. The idea and the rationale for the procedure is that it involved careful patient selection with inclusion and exclusion criteria specifically designed to select for patients that were likely to respond to neoadjuvant therapy and do well after transplantation. We used operative staging to avoid transplantation for patients destined to develop distant metastases. As far as the radiotherapy and chemosensitization, we knew that the high-dose therapy was effective, but would predispose to future liver problems, and those would be obviated by transplantation. With transplantation, we remove all residual disease, and R0 resection is almost always possible because the hepatic margin is irrelevant. It does treat the underlying PSC and avoids liver failure that was due to the high-dose radiotherapy. Also, as far as the timing of therapy and transplantation, by doing the transplant and the staging operations after the administration of neoadjuvant therapy, we felt that we would avoid some of the dissemination of a tumor that was that would be possible with both procedures. Patient eligibility is our previously published criteria, which have now been adopted by UNOS in the United States for MELD exception points, include a diagnosis of cholangiocarcinoma based on a transluminal biopsy or brush cytology, or a malignant appearing stricture and at least one of the following: an elevated CA19-9 greater than 100, biliary ploidy by fluorescent in situ hybridization, or a mass at the site of the stricture on cross-sectional imaging. Later on, when we first required that the patients have unresectable tumor above the cystic duct, but we have done pancreatoduodenectomy for when we've detected microscopic involvement of cholangiocarcinoma at the common bile duct margin. And we've also transplanted potentially resectable patients, but their disease was arising in PSC. Obviously, they need to have absence of intra and extrahepatic metastases and otherwise be a candidate for transplantation. Our exclusion criteria are fairly well known, and as you would expect, those shown in white were the ones that we started with. And then as we learned more during our procedure, we learned to avoid those patients that had prior biliary resection or attempted resections who had presumed had dissemination of tumor during those procedures. We also learned to avoid patients that had had a transperitoneal biopsy or a fine needle aspiration, including those done by EUS, which resulted in seeding. The one patient that we didn't detect the seeding at staging recurred after transplantation. And tumors that extend 3 centimeters perpendicular to the bile duct also do quite poorly, although the longitudinal extent of tumor along the duct does not seem to matter. Our results overall from 1993, and these were updated in December of 2019. Since that time, we've added about 30 more patients, but our results the percentages are all about the same. We've enrolled 376 patients in neoadjuvant therapy. 305 have gone on to operative staging. overall, about 20% are positive at staging, which precludes transplantation. And we've done 237 liver transplants, 155 with deceased donors, 81 with living donors, and 1 with a domino donor. Our overall patient survival at 1, 5, and 10 years is shown with 81% and 52% 1 and 5 year survival, and 44% 10-year survival with 80 patients still available for follow-up at that time. This is since the time of registration on the waiting list. When we look at patient survival after transplantation, we transplanted 237 patients with 1, 5, and 10-year survivals of 92, 68, 60%, and we followed 78 patients for 10 years. It's important to distinguish the different behaviors of the cholangiocarcinoma. Those that arise in PSC do better than those that arise de novo. So we always separate those groups when we're reporting our results. We've treated 228 patients with underlying PSC with neoadjuvant therapy. At staging operation, only 27 or 14% had findings precluding transplantation, and we have performed 153 liver transplants for patients with cholangiocarcinoma arising in PSC. With cholangiocarcinoma arising de novo, it's a smaller part of our experience. 148 patients have been enrolled in the treatment protocol. Of the 117 patients that underwent staging, 31 or 26% had findings precluding transplantation, which is almost twice the positivity rate of those with underlying PSC. 84 have undergone liver transplantation. When we look at patient survival with intention to treat analysis, shown in green are the patients with cholangiocarcinoma arising in PSC, and as you can see, the 1, 5, and 10-year survivals are 78, 58, and 51% compared to the 1, 5, and 10-year survivals of 84, 41, and 32% for the patients with de novo cholangiocarcinoma. For those that have undergone transplantation, there still is a difference. The PSC patients do a bit better, showing 93, 74, and 67% survival compared to 91, 58, and 47% survival at 10 years. We watch this figure very carefully because we look at 50% 5-year survival as the minimum survival that we would consider a reasonable chance for success. We've learned to predict failure. There's factors that predict the patients that will fall out before transplantation, including those that have a very high CA19-9 level at the time of presentation, those with a visible mass and a high MELD score, things that you would think that would be pretty obvious. Those that are more likely to develop a recurrence after transplantation are those that still had a high CA19-9 level at the time of transplant, had residual cancer in the explanted specimen, and particularly those with perineural invasion. Overall, recurrence rates have been about 26%, 20% for those with cholangiocarcinoma arising in PSC, and 38% for those arising de novo. Our experience has been corroborated by other centers in the United States and in Canada. 12 other high-volume U.S. centers that had each done at least 3 patients were combined in a paper, including our series, and looked at an intention to treat survival of 53%. And this is where we learned that, you know, patients, especially those with tumors greater than 3 centimeters, didn't do very well. This experience, though, did include our patients, which is a vast majority of the volume. Separate from our experience is the U.S. Extrahepatic Biliary Malignancy Consortium, which is a group of 11 centers in the United States, 3 of which do transplantation for cholangiocarcinoma, including Emory, University of Wisconsin, and Washington University in St. Louis. A couple of years ago, they published their experience of 70 patients and their intention to treat survival of 53%, and their survival after transplantation of 61% is quite similar to ours. And importantly, their ratio of PSC to de novo cases is also fairly similar to ours. This shows their experience. They did compare it with resection, and we maybe can talk about that a bit later and how we choose to proceed either with transplantation or resection. But basically, you have to look at your results with resection, and then, for instance, you have 40% 5-year survival, and then multiply that by the likelihood in percentages that you would be able to achieve an R0 resection. So if you have a 40% 5-year survival, but you only have a 50% chance of achieving an R0 resection, your intention to treat survival is only 20%. Some of the special problems that we face include medical and neoadjuvant therapy-related problems, which can be quite significant. Almost all of our patients are hospitalized while they're awaiting transplantation with cholangitis or hepatic abscesses at one point or another. They can decompensate, particularly if they have underlying cirrhosis. There can be common bile duct involvement microscopically about 10 to 15% of the time, which we see with PSC, and technical problems and late vascular problems related to the neoadjuvant therapy. This shows the effect of the neoadjuvant therapy on the hilus of the liver. It causes a lot of centralized necrosis, and most of the time the biliary epithelium is completely necrotic. We have encountered common bile duct involvement, and we always wondered whether or not we should or should not do a pancreatiduodenectomy. On 3 patients, we re-excised the duct and got a negative margin, but all eventually recurred. And thus, we have now proceeded with pancreatectomy when we get a frozen section that shows cholangiocarcinoma at the margin. We've also done several on-block pancreatiduodenectomies, and endoscopically, we always do a blind biopsy of the common bile duct, and if that's positive, we've gone ahead with an on-block pancreatiduodenectomy. Overall, we've had about 38% 5-year survival on the patients that have had either the on-block or the sequential pancreatiduodenectomy. So our recommendations moving forward are for cholangiocarcinoma arising in the PSC that neoadjuvant therapy and transplantation is emerged as the treatment of choice, and that for cholangiocarcinoma arising de novo, we still feel that we should resect resectable disease. There was a French study that was attempting to show that, but they've had enrollment difficulties, and that we should reserve neoadjuvant therapy and liver transplantation for patients with unresectable disease. And thank you very much again for including me in this conference, and I'm looking forward to our discussions.
Chuck, I have a question if no one else has a question. We have had a couple cases of what appear to be obvious hilar cholangiotumors that are causing strictures, jaundice, but we can't get the diagnosis. And the brushings are showing atypical cells, but not cancer, and the FISH is inconclusive. We've had struggles with our medical oncology team about proceeding with your protocol. And we've done a bunch of cases. How do we get around this? What's the answer? Do you just keep plugging away with ERCPs to try to get a tissue diagnosis, or do you guys proceed?
If there's a malignant appearing stricture and a mass at the site of that stricture on cross-sectional imaging, the likelihood of that not being malignant is incredibly low. Now, granted, it can happen, and we've certainly had those cases. But if, and particularly if you watch it for just a short period of time and observe growth of that lesion on cross-sectional imaging or on cholangiography, we would proceed. More difficult for us is the diagnosis of cholangiocarcinoma arising in PSC, because we now screen those patients, and oftentimes we'll get polysomy on the FISH, and we won't see the malignancy. And so we'll watch and watch, and we'll repeat it, and almost event. And we've studied that and published that, and most of these patients will go on to have an invasive malignancy. One could actually argue you could transplant them there so early that you wouldn't need the neoadjuvant therapy, but we have not done that. If we're going to proceed with the transplant, we've given them the neoadjuvant therapy. So I have no data to justify what I'm about to say, but I would guess that there's maybe even 10 to 15% of those patients may not have an invasive malignancy, even though they may have carcinoma in situ. And then everything is so obliterated by the neoadjuvant therapy, there's just no way to tell. But generally, these are young patients, and we know that if we waited, they would have cancers.
Chuck, hi, good to see you.
Hi, Avi, good to see you.
I always enjoy this talk of yours. But I still can't get around how you do the biliary drainage for these guys. And I mean, is it always endoscopic or?
We prefer endoscopic. And when patients come to us with external drainage, we'll convert it to endoscopic drainage prior to transplantation. We've got excellent endoscopists along with interventional radiologists. But the management of these patients while they're awaiting transplantation and while their hilus is becoming necrotic is a challenge. Some people will sail through it, but for the vast majority have some problems. And we've had substantial problems, including tube-related cholecystitis, perforated gallbladders. We've had, when Nebraska actually first started this protocol and they were giving 6,000 rads of brachytherapy, they had duodenal perforations. We've had perforated ulcers. But it's not for the light-hearted to take care of these patients.
So you could start percutaneously and then convert them to endoscopic by rendezvous procedures, or is it always endoscopic?
We've done that, but we prefer endoscopic by far. We've had a couple of tube site recurrences.
Sure. So, but they're not a deal breaker. If they've had a percutaneous drainage, PTBD drainage, and then they're converted to endoscopic through a rendezvous route, they pass the wire across and then you pass the stent. That's okay, right?
Right.
Yeah.
I have a comment. Can I make a comment?
Yeah, please go.
I was listening to this talk. We do face these problems of atypical cells, but we take the view that if there is a mass, soft tissue mass, and it shows atypical cells, I think that should be enough to make a diagnosis of carcinoma. It's a perfect. We don't get frank tumor cells, but on radiology, if there is a mass with atypical cells, I think it should be taken as positive.
Dr. Reina, my point is, I know what we think, but the medical oncologists want tissue, and without tissue, they're not going to give chemotherapy, and that's what I've been told by my team. So I don't know if others have medical oncologists that feel the same way, but most of them will not give toxic chemotherapy without tissue.
Yeah, we do face the same problem. We do face the same. Yeah.
Dr. Rosen, excellent talk. We have a question in the chat box. I think you did address that situation about the distal margin, and that's very problematic when you drain the system and have a radiation therapy before. So how do you assess and go ahead and make a decision on table frozen for distal margin for a Whipple's procedure, or you do for sequential?
With our de novo patients that have underlying PSC, we've never seen the distal margin be positive, so we don't bother to check that anymore. With the patients that have PSC, we get a frozen section. Frozen section was actually developed at Mayo Clinic, and so there's a historical precedent for us, and our pathologists are very good at reading those, and they're very quick. And if that's positive, we'll proceed with the pancreatoduodenectomy. But more importantly, what we've learned is prior to starting neoadjuvant therapy, we get a blind brushing and a biopsy of the common bile duct within the head of the pancreas. And we do that before we ever start. And if that shows microscopic disease, those patients should have an en-bloc pancreatoduodenectomy. It's a little more difficult to take out the head of the pancreas with the liver and leaving the duct intact. Getting around that portal vein can be a little bit difficult from the radiation treatment, but those patients do a little bit better than if we cut the duct and find it at the margin.
Dr. Rosen, one question. In case if you encounter baseline cirrhosis in the patient with cholangiocarcinoma, is your management any different? Will they be able to tolerate toxic chemotherapy drug?
Most of our patients can that have underlying PSC. That's obviously cholestatic liver disease. We've had an occasional patient that was too sick to get neoadjuvant therapy. And the hard decision then, if they're too sick to get neoadjuvant therapy, they're too sick to do the transplant as well. Because to do the transplant without neoadjuvant therapy is destined to failure. We've had some patients that have had cirrhosis due to underlying conditions other than PSC, and those have to be evaluated. And we've had several with hepatitis C, several with alcohol, even some with NASH.
Yeah, Dr. Rosen, excellent talk. This is Vivek here. I hope you are doing well. Uh, just a small question. We are presently managing a patient of hilar cholangiocarcinoma, which is unresectable. But somehow this patient came from another center where exploratory laparotomy was done in this patient, and they found cirrhosis and they closed. We actually don't know the status, whether they touched the tumor, took biopsies or nothing. What are your suggestions on this?
Um, we've had the same situation arise. If they did absolutely nothing, we would still go ahead then with the protocol. But if there's any tumor manipulation, dissection up in the hilus to assess for resectability, then we would not go ahead. The few patients that we've done in that situation have all had recurrences.
Yeah, that sounds good. Thank you.
All right, Chairperson, we can move to the next talk.
Sure. So thank you, Dr. Rosen. The next talk is by Dr. A.S. Soin, who is not only my mentor, and he is also the chief liver transplant and hepatobiliary surgeon at Medanta, the Medicity, and he is chairman of the Medanta Institute of Liver Transplantation and Regenerative Sciences. So I invite Dr. Soin to start his deliberation. Thanks.
Thank you, Ravi, and thanks, Vivek, for the invitation. And it's great to see you all, even if it's online. We all long for the day when we can meet in person, of course. So, living donor liver transplantation in HCC with portal vein tumor thrombosis. Whenever you see this picture, you know, a large HCC with a portal vein tumor thrombus, you basically tend to write off these patients to palliative treatment. And that's because it is well known that patients with portal vein tumor thrombosis, if left untreated or treated with palliative treatment, their median overall survival will be a few months, and less than 10% of them go to 2 years. And in most centers and in the minds of most surgeons, this is an absolute contraindication to liver transplantation. In the BCLC algorithm, they're recommended to have only tyrosine kinase inhibitors, and their median overall survival is between 7 and 10 months. Most guidelines contraindicate this, not just for transplantation, but also for resection. But the big question is portal vein tumor thrombosis always equal to systemic disease? Well, apparently not. If you look at this seminal paper by Vincent Mazzaferro, which he published over a decade ago, where he looked at about 1,600 odd patients, a third of whom were beyond UCSF, and he looked at the survivals of patients according to tumor size and number and whether they had vascular invasion. 40% survival at 5 years was possible for 2 tumors, with the larger tumor being 7 centimeter with vascular invasion. This was, of course, both micro and macro. But the point is, vascular invasion does not always mean no possibility of long-term survival. So now let's remind ourselves how we label these patients with portal vein tumor thrombosis. VP0 is no thrombus, VP1 is distal to the second order branch, VP4 is the main portal vein, VP3 is the lobar portal vein left or right, and VP2 is the sectoral or the segmental portal vein. And we consider VP1 and VP2 segmental, and of course lobar or lobar portal vein tumor thrombosis, VP3 and VP4. There has been a change in this dogma that somebody with a portal vein tumor thrombosis cannot live long with the use of radiotherapy, both stereotactic body radiation therapy as well as transarterial radioembolization. So there have been series over the last 10 years that have talked about 30 to 40% complete to partial response for patients with portal vein tumor thrombosis with or without IVC tumor thrombosis with SBRT or stereotactic body radiation therapy. And there have been sizable number of patients, 41 patients in this one and 120 patients in this one, and they both had, a third of them had complete response and 40 to 50% of them had partial response. There have been some papers from Korea, from South Korea. This is KS Su's group. It was a small series of 11 patients, and they did not use any downstaging therapy, and they did transplants for patients with portal vein tumor thrombosis, and they had an overall survival of 5 years at 63%. And of course, if they were PET positive, if the tumor was large, or if the AFP was high, higher than 20,000, and if the main portal vein was involved, then they had worse prognosis and the others did better. Another paper from the Asan Medical Center group, SG Lee's group, where they had 17 patients with portal vein tumor thrombosis, and they downstaged these patients, and after successful downstaging, they were able to get 3-year disease-free and overall survivals of 57% and 60% respectively. What did they use for their downstaging protocol? It was TACE and radiotherapy. This was followed by living donor liver transplantation. 4 patients published here, and 2 of them had long-term survival. And again, these were patients with PVTT that were downstaged. Another paper with 8 patients with PVTT, and they had hepatic artery intrahepatic chemotherapy and CCRT, and they had 87% 1-year disease-free survival versus others who had less than 10% survival if they had standard therapy without transplantation. We published our experience, and I believe this is the world's largest experience of transplantation among patients with HCC and PVTT. And to take you through our experience, among a total of nearly 3,200 living donor liver transplants, we did 465 patients with HCC. 410 of those had no PVTT, and these were all comers. That means all tumor size and numbers. And 55 of them had portal vein tumor thrombosis. 25 of them were downstaged and then transplanted, and 30 of them were transplanted without downstaging. Now, our protocol for downstaging, we assess them with a triphasic CT angio, with a PET CT, and as long as they have Giles A or B cirrhosis and they have more than 70% non-tumor liver available, they undergo stereotactic body radiation therapy, which is targeted on the portal vein tumor thrombus, wherever it is, and tear, which is obviously meant for the primary tumor, as well as the contiguous portal vein tumor thrombosis. In some cases where there is segmental PVTT, we are able to do TACE, and occasionally we supplement this with RFA. So what we would do is, once the pre-procedure assessment is good, we would do the assessment for tear to look for shunts. So that's tear 1. We would put the fiducials to label where the SPRT has to go. Then we would do the SPRT, and then we would follow this literally 2 days later with tear 2, which is the actual delivery of the yttrium 90. The dose of radiation given is 45 to 55 gray over 5 to 7 fractions in about a week. What we do is we evaluate the response in terms of alpha fetoprotein. Now, over the last year and a half, we've got 2, and looking at contrast enhancement and FDG uptake at 6, 8, 10, 12 weeks. So we do it every 2 weeks. And then we proceed if there is no FDG 18 uptake and no arterial enhancement with contrast in the portal vein tumor thrombosis. So if the portal vein thrombus has become just bland, that means there is no arterial enhancement and no FDG uptake, we would then consider this as response. And if there is partial response, we would wait, stroke, repeat SPRT, and then follow this up with living donor liver transplantation. So we've had, with this protocol, 82, 57, and 57% 1, 3, and 5-year overall survival. And if you compare this with alternative therapies, That means just palliative RT or sorafenib alone. We've had hardly anybody lives to 2 years, even if they've had palliative radiotherapy, and nobody lives to 2 years if they have had only sorafenib or no treatment. So if you look at transplant benefit at 36 months, with this protocol, each patient who has this protocol of downstaging followed by transplant has a transplant benefit of approximately 23 months. So when we analyzed these patients to see what the prognostic factors were, for overall survival, the prognostic factor was pre-liver transplant alpha-fetoprotein and tumor grade. For recurrence-free survival, it was pre-transplant alpha-fetoprotein. For overall survival, it was tumor grade. And for recurrence-free survival, it was alpha-fetoprotein more than a 400 at diagnosis and a delta AFP of less than 2,000. So basically, tumor biology is the king. We've all understood and agree with that. And this decision to go ahead with including such patients in the protocol is dependent on a multidisciplinary team, the so-called transplant oncology board, which consists of the surgeon, the hepatologist, the pathologist, the diagnostic and the interventional radiology teams, and the medical and the radiotherapeutic oncology teams. And then we decide what's best for each patient. So to summarize, all patients with HCC with PVTT should not be written off or relegated to palliation. Many can achieve long-term survival with living donor liver transplantation after downstaging with commonly TARE and SPRT. Of course, the center and the surgeons must ensure good recipient outcome, which is not related to the cancer, and safe donor surgery with zero mortality. Conversion rate to transplantability in HCC patients with PVTT using downstaging therapy is a total of around 65%, but it is better among patients who have segmental portal vein involvement rather than lobar or main portal vein involvement. Response evaluation, documentation of downstaging, and adequate waiting period of 6 to 12 weeks after downstaging is essential, especially in patients with lobar PVTT. Thank you very much.
Thank you, sir, for this excellent talk. So there is a question in the chat box. Now, in the past, PVTT was considered as distal spread. With this protocol, do you think that now we can call it a local rather than distal spread?
So, Ravi, the point is, yes, it is not always distance spread. In some cases, it is local spread. We also looked at, interestingly, the histology of the tip of the thrombus when we remove these explant livers. And we found that out of 19 cases that we looked at, 18 did not actually have tumor at the tip of the thrombus. So what I'm trying to say is that the part that you think will result in systemic spread, that part actually didn't contain any tumor. So yes, it is not always systemic spread. Sometimes it is just local contiguous spread, which may be contained.
A question that I have is, did you find any more surgical difficulty in these transplants compared to a regular transplant?
I mean, not difficulties that were insurmountable. I mean, I think for 3 or 4 cases, we've had to put portal vein conduits because they were pretty fibrosed. And we had to do thrombectomies in a few of them, even though it was bland thrombus. One of them had to have a jump graft from the SMV, but you know, all of those were managed.
Would invite more questions from other panelists and audience.
Dr. Soin, do you think that we're going to feel the same way about hepatic vein involvement in the future, just like we're talking about portal vein?
So I don't really know the answer to that, but we've had 3 cases with, and it's there in the paper that I talked about. We've had 3 cases which we've tried to downstage with hepatic vein tumor thrombosis involving the right vein and the middle vein. And one of them actually had a small nubbin going into the IVC as well. And they were all downstage. I mean, we attempted this on, I think, 7 or 8, and 3 were able to be downstaged so that the arterial enhancement and the FDG avidity went. And those 3 were transplanted, and 2 of them recurred and 1 did not. So it's a very small experience.
Avi, tremendous experience. Congratulations. One of the things that crossed my mind is sometimes we've seen the tumor thrombus regress with whether we've done chemoembolization or tear. And I was wondering if you looked at that to see if that would be a prognostic factor for those that have tumor thrombus that regresses with the downstaging, even to the point of opening up part of the portal vein, at least partially. Do those patients behave better after transplantation?
So we did look at it, and it didn't make a difference in our series, at least. I presented the prognostic factors. They were all biological.
Yeah. I was just looking for something I could use with my team to advocate for going ahead with these patients.
Yeah. It's going to be difficult in the US with all the, you predominantly what? You do 90% cadaveric transplants, is that in your center? Or?
We're about 90% deceased donors, yeah.
But you could push a case for doing a living donor liver transplants for such patients.
Yeah, because you were about 60% 3-year survival. And
5 years.
you know that, and that'll pull down our living donor results, which are looked separately from our deceased donors, so we get caught with network participation and that sort of thing. It's tough for us to push it that far, even though maybe in the patient's best interest.
But Chuck, when you're a large volume center like you guys are and we are, I mean, a lot of the patients pull down your results, right? So I think you have to live with that. I mean,
but we only do about 20 living donors a year, so it becomes more significant.
Just one quick question: when we are considering LDLT and SBRT for PVDD, will your waiting time ever wait if you are treating, say, VP1 versus a terminal VP3 or VP4?
So the thing is, if you're treating a small tumor volume and it has responded in 6 weeks, we would wait another 4 weeks and go ahead. But if it's a largish tumor volume in the portal vein, this is like intuitive. Obviously, you can't just do studies on everything. So if it's a largest tumor volume, we would often wait 6 weeks, 8 weeks after we've documented response. So I think we tend to wait longer if it's a large tumor volume. That's all. But
in patients whom TARE or SVRT was given and they were not transplanted, was there any difference in the local control on the imaging follow-up and also the survival as compared to the medial that is documented?
So I did show a slide on survival of patients with radiotherapy that either became palliative or was palliative by intent. And I think 42% of them lived a year and 17% of them lived 2 years. So significantly less survival.
I think if you have over the questions, thanks a lot, Dr. Soin, a very incredible lecture. So now we'll like to take up the
Thank you.
Yeah, we'll take up the next topic, and the topic is liver transplant for colorectal liver metastasis. And we have Dr. Pal Dagline. He's a very famous abdominal transplant surgeon. He has maximum papers on liver transplant for colorectal metastasis, special interest in transplantation, and also various transplant techniques. Over to Dr. Pal Dagline.
So thank you very much for inviting me to give a talk on this topic. I will try to highlight the most important aspects of pursuing liver transplantations for colorectal metastasis, obviously a highly controversial issue. So in general, in transplant oncology, we are talking about optimal patient selection. I think if we review all the talks of the day, it's all about testing which patient could be considered based on various criteria, considering both tumor load and what we perceive as favorable tumor biology. And in this context, we have to ensure really that we're dealing with liver-only metastatic disease, although that might be slightly difficult. We have to exclude aggressive tumor biology. And one should apply the documented selection criteria that now are in the literature. And you have to have an adequate observation time to prove disease stability. In essence, to all the three first points have to be documented over time by observation time. Now, so for the workup, we rely on combining CT, MRI, and also PET-CT. The latter is, of course, very important in order to eliminate extrahepatic disease. Now, the Achilles heel of this protocol is that for the lungs, it's really hard to determine whether the patient has minimal nodules that later turn out to be cancer. The first criteria were derived from the first prospective trial that you probably all know about, the Zika trial. And based on this, we have what we term the Oslo score, which is contains maximal tumor diameter, CEA level, response to chemotherapy, and time interval. And for all of you familiar with prognostic scores and liver sections, these are common themes also in those scores. And as you can see, if you have 0 to 1 factor, everyone survived in the trial. Whereas if you have a full house with all the negative factors, no one survived 3.5 years. Now, moving to the sequel study of the Zika 1 trial, named the Zika 2 study, all the patients we recruited in that trial essentially have Oslo score of 0 to 1. And that yields a 5-year estimated survival of 83%, indicating that it is possible to select patients fairly well in order to obtain good long-term survival. A very important aspect, and this is probably underutilized in assessment in HPV surgery in general for colorectal metastases, is the importance of metabolic tumor volume. It's fairly well documented for a range of cancers, being sarcomas, melanomas, breast cancer, head and neck cancer, that metabolic tumor volume is a prognostic marker for cancer biology. This is just an example from chemotherapy of non-resectable cancers, non-resectable liver metastases. And when we're talking about metabolic tumor volume, this is the lesion volume with an uptake of over 40% of maximal standardized uptake volume. And you can obviously calculate this for each lesion. Then you get metabolic tumor volume for the liver. Now we have also looked at this in liver resection. This was just a study comparing MR, CT, and PET to look at the sensitivity to detect liver tumors. But when you look at metabolic tumor volume here, there is a cutoff at about 6 cc's. Patients having low metabolic tumor volume all survive after liver resections, whereas those having above have much worse survival, although the survival is rather typical of liver resection, around 40 to 50%. So we have been very interested in this in liver transplantation, and this picture on the left shows you 2 patients with the enhancement in the liver, and the metabolic tumor volume is obviously quite different. The upper patient has several tumors, but not much enhancement in the liver. He is alive for more than 11 years. The lower patient died after 2.5 years after transplant. And we have looked at this in an early publication, and the cutoff value for metabolic tumor volume in liver transplantation appears to be around 70 cc's. When above this, it predicts worse outcome quite consistently. And we consider MTV to be a combined marker of both tumor load and biological activity. Interestingly, the cutoff value is considerably higher than those observed in chemotherapy and liver resection by a factor of about 10 times. So you can use various criteria to actually sort of determine how stringent you want to be in terms of selecting your patients. So applying just the Oslo score and keeping this from 0 to 2 would yield a 5-year survival of around 67%. If you apply MTV, you end up with about 78%. And if you are very stringent and use the phone clinical risk score and limit this to 0 to 2, in our series, we have 100% survival. Obviously, that's probably not accurate, but giving you a sense of that, you can actually determine how stringent you want to be. Now, if you apply Oslo score, this will incorporate around 60% of the patients we have actually transplanted through the years. If you use MTV, it would apply to about 50% of the patients we have transplanted. And if you decide to use the phone clinical risk score, we would just transplant 30% of the patients we have transplanted. Now, so this gives you an idea of how to do it. I will just go through stringent, how you can do stringent patient selection to ensure to avoid futile use of liver grafts. So if you have unresectable patients, your first thing to do is to eliminate those that clearly shouldn't be included, being extrahepatic disease. Right-sided primary, we have fairly bad experience with. Also, if you have undifferentiated tumor or BRAF mutated tumors, poor performance status, and older patients, these should receive standard of care treatment, being palliative chemotherapy. Whereas if you have a patient without these criteria, they should receive a state-of-the-art chemotherapy. They have to have a treatment response of at least 10% RECIST. If not, you have to continue chemotherapy. And you have to evaluate these patients against these criteria I have briefly mentioned, largest lesion and CEA being part of the Oslo response, or if you choose to use MTV. If they don't satisfy this, you have to continue chemo or other local regional treatment. Then you have to observe, keep the patient in this process for at least 12 months. If not, you continue. Then you can list for transplant. But finally, you have to explore the hepatoduodenal ligament during transplant. If positive, they should not be transplanted. But if negative, you can go on to transplant. Recurrences are, however, a fairly big problem as it is in resection. So many of these patients will recur. The important thing is that 70%, up to 70% of the relapses are pulmonary metastases, and we have clearly shown that the immunosuppression does not accelerate growth of these metastases. We have also shown that the majority of these lung lesions can actually be resected with curative intent. And interestingly, probably 40, maybe up to 50% of the lung mets may be staging failures due to methodological limitations in diagnosis at the time of evaluation. And this is clearly indicated if we look at the long-term data from the Zika-1 study. This is now submitted for publication. So those having Oslo scores of 0 to 1 have an observed, not estimated, but observed 10-year survival of 50%. And I can tell you that every one of these patients have had lung resections. And most of them, the the shortest interval from lung resection now is more than 3 years. So we consider these patients cured. The same phenomenon is obvious from the SICA-2 trial, where the disease-free survival at 3 years is about 35%, but the 76% of the patients have no evidence of disease due to the fact that most of them can be resected for their lung mets. I'll just, in case someone has heard this talk hundreds of times, I just thought of provoking you a little bit and mention one more thing, which is highly controversial. All our experience is in unresectable disease for obvious reasons. And one might tend to think that resectability is an important issue in this context. It is, of course, very important in terms of that most patients with resectable disease should be resected. But resectability is foremost a technical anatomical factor and not really a predictor of tumor biology, meaning that if you have borderline resectable disease or patients requiring all sorts of measures and high-risk procedures to get resected, one could ask the question whether transplant could offer a benefit in that setting. This is just a teaser of that. We have actually looked at a consecutive database together with a fellow who spent a year here, a fellow from Italy, and we applied the SICA-1 inclusion criteria to a set of resection patients. So we used the same inclusion criteria for transplants and liver resections, being liver-only disease, good performance status, at least 6 weeks of chemo, no contraindications for transplant, and we measured the survival from first surgical intervention, being either surgery or transplant. And if you just compare them out of the box, there is no difference between resection and transplantation. But if you look at high tumor load, which is a very, very reproducible bad prognostic factor in liver resection for colorectal liver metastases, this is what happens. So the 5-year survival in resection is 16.7%, whereas in liver transplantation, we are looking at 78%. This is obviously nothing, this is a very preliminary result, but I can say that we are now doing a multicentric approach to this concept, and maybe you will hear something about this later on. So in conclusion, I think our experience clearly indicates that liver transplantation can be a viable option in carefully selected patients with non-resectable colorectal liver metastases. And if you apply stringent selection, you can obtain a 5-year overall survival rate that is acceptable compared with other indications for liver transplantation and other transplant oncology indications. Aggressive treatment for all resectable recurrences is recommended. In particular, you should pay attention to the lung metastases, as these, if they are few and resectable, really do not have as large impact on survival as one might think beforehand. Now, regarding my teaser and my provocation, I mean, this has to be ideally assessed in future trials, whether borderline resectable patients also should have the option of transplant consideration. So thank you very much for the invitation, and I'm happy to answer any questions.
Indeed, a very good lecture, sir. And obviously, there are issues with case selection, and also it's a controversial topic. I just one question: if we have a colorectal Mets who has undergone a transplantation, and then develops a lung metastasis later on versus a patient who hasn't ever had transplantation. So between you and probably Dr. Raina, who's our medical oncologist, is there any issues in selection of a systemic therapy, chemo versus immuno for a transplant and a non-transplant? Will there be any challenges, limitations?
So we have looked at chemo treatment in these patients. So they respond to chemo fairly as you would see in the non-transplant setting. There is somewhat increased toxicity in terms of mucositis and diarrhea, but no increased bone marrow toxicity. If you are looking at patients with lung mets only, we don't give chemo at all. We consider this a resectable disease, and we don't give chemo. The only thing we do is to observe them until the metastases are so big that thoracic surgeons will find them reliably. Because our early experience is that if you go in when the metastases are very small, they will miss them in too high proportion. So the limit there is usually around at least 10, but preferably 15 millimeters.
Were you talking, or were you referring, can I speak, were you referring to the role of chemotherapy after the transplant?
Well, we don't give chemo after the transplant.
Okay, that's what I said.
Yeah, right, okay. So we just give chemo if the patient is considered palliative. Otherwise, we don't give chemo.
Okay. Right. Not till progression.
Right.
Okay.
Excellent talk, Paul. And definitely you have a great outcomes. There's a question in chat box from Albert Chan. Is there any impact of KRAS status on the outcome of liver transplantation?
So we have obviously looked at that. We cannot find any statistically significant impact. And the reason I say statistically is that that might be a lack of power, actually. But that also translates to that I don't believe KRAS mutation is a hindrance for transplant. So I would go ahead transplant KRAS mutant patient if the other factors are favorable. But if some years down the line, if we end up looking at, together with other centers, looking at hundreds of patients, I don't, it might just be the case that KRAS is negative also in transplant, clearly.
Well, there's a question from Shimul. Are you doing hepatic artery infusion in Oslo?
We are actually now just starting a trial on clearly unresectable patients where they will go into hepatic artery infusion, and they will have a 3-arm randomized trial between hepatic artery infusion only, hepatic artery infusion plus resection, and hepatic artery infusion plus transplant.
There's another question from Alejandro. Regarding the resectably high-low tumors, do you think you are talking about the similar groups regarding retrospective data?
So I didn't show you that. The only difference between these two populations is the tumor load in the transplant population. They are similar on every fact, on all common risk factors.
Just a comment on that point. PAL has a paper coming out in JAMA Surgery soon. When you look at their data, these tumors are well beyond what anyone is resecting. These are 5, 10 tumors in the liver, huge tumors. Some patients have 15 tumors. This is the real deal here. These are not 1 or 2 lesions compared to the retrospective data that Alejandro is talking about from surgical series. So I think this is a different patient population. It's a very impressive series.
And I think what this data is showing, maybe down the line, maybe we are going to go ahead with upfront liver transplant for those patients rather than being for resection. I think time is not too far for that.
Yeah, I don't want to be misunderstood, but I don't mean that we should start doing transplant in resectable patients. My only simple point is that I think transplant should be on the inventory list, on the possibility list in colorectal metastases, and not patients shouldn't be simply sorted after whether some surgeon consider this to be resectable disease. If you look at the outcome of AILBS, the 5-year survival after AILBS in 500 cases reported recently is 27%. And I mean, that's not great.
Thank you. Thank you, Paul. And thank you all the chairpersons and all the speakers for this session. Dr. Rosen, you have a question?
I did. Paul, congratulations. You and your group have been pioneers in this effort and have really deserve a lot of congratulations for all your hard work. As you know, you can modulate outcome by selection criteria, and we can do that for every metastatic disease that we transplant, or even every primary disease that we transplant, particularly neuroendocrine cancers. That's been shown as well. And as you know, I just struggle though, because when you modulate outcome by looking at selection criteria, you change the natural history of that group that you are treating. And if you look at a reduction in tumor burden, obviously, if you go from 50% to 20%, you're going to get better results. And the people that you go to 0% have fantastic results. But the problem is they didn't need the transplant in the first place because they don't even have a tumor. So I just keep struggling with that. How do we know what the benefit is? And I struggle it with the colorectal metastasis. I actually struggle it with the neuroendocrine tumor metastasis as well. And we've tried to minimize, for instance, in neuroendocrine cancer, the tumor load to get better results. But, you know, a patient that you might gain 5 years that still dies from their disease, but that was miserable with tumor replacement and ascites, that would have lived another couple of months, may have had a 4 or 5 year survival with transplant, which would be fine, even though they had tumor replacement of the liver. How do you deal with that, or how should we figure that out for colorectal metastases?
Well, we try to look at it. So obviously, the ideal way to do it would be to randomize, and but we try to do this by we wrote a paper looking at where we compared the transplant population with the Nordic 7 trial, which is a chemo trial. Which is fair, that trial is very well documented. So the survival there is about 8% at 5 years. And so when you look at our patients, the CK1 observed results there, we have patients, we have the low risk patients there surviving 50% at 10 years. So clearly I'm quite convinced that there is a clear benefit. Because there is no survivors in comparable patients from the Nordic 7 trial. And the Nordic 7 trial is not very deviant from the other chemo trials around. It's essentially the same results you see.
So they're not operatively staged?
Well, no, you're right about that. So to do that, you would have to do it prospectively, and that will take some time. But so I see your argument, but to develop this, you need to start off somewhere. And that's the way you have done it in cholangiocarcinoma. And that was the way we did it in HCC. We started out with lousy results. Then it turned out someone showed us how to select patients. And I guess that's where we are at now, where we are in 1996 in a way, demonstrating some criteria you can use, and then we have to move on.
I'm not being critical, I'm just commiserating.
Yeah. And I appreciate it. I've learned a lot from my short stay at the Mayo Clinic when we learned about the Mayo protocol.
All right, guys, thank you for this excellent session. In the interest of time, we need to move on for the next session. It's on the debate on resection versus transplant for cholangiocarcinoma. I would like to invite the chairperson for this session, Dr. Vinendra Pamecha, who is a professor and head of liver transplant HPB surgery at Institute of Liver Sciences, New Delhi. Dr. Lucas McCormack, who is the chief of liver surgery and transplantation at Hospital Alemán of Buenos Aires, Argentina. Dr. Alejandro Saraballo, who is the associate professor of surgery, Medicine School of Zaragoza University, and honor council member of Spanish chapter of IHPBA from Spain. Dr. Rahul Kakotkar, who is a senior consultant and liver transplant surgeon from Vision Multi-Speciality Hospital, Goa, and Dr. T.D. Yadav, who is a professor of surgery in Department of Surgical Gastroenterology at PGI Chandigarh. The moderator for this session today is Dr. Karim Halazoon, but unfortunately he needs to rush for a surgery. So I'll be moderating and take questions, but for the speaker, we have Dr. Flavio Roca. He's an associate professor of surgery, Hedinger Chair and Division Head of Surgical Oncology. He's a physician-in-chief at Knight Cancer Institute, Oregon Health and Science University, United States. He's also a surgical lead of the International Cholangiocarcinoma Research Network, and he's going to talk about for the resection in cholangiocarcinoma. Dr. Roca.
Can you hear me, Dr. Singhal?
You're nice and clear.
Perfect. Let me share my screen. Can you see that?
Yep.
Wonderful. Okay, great. Well, I'd really like to thank the organizers for the invitation. It's a real pleasure. And again, I share, just like as Dr. Rosen mentioned, that we could not do this live, but I think in some ways we're able to get a lot of participation through this venue. So I was asked to talk about the role of resection for cholangiocarcinoma and debate perhaps its merits over transplantation. Although I'm now somewhat intimidated by the wonderful panel of surgeons that were just in the last session, including my good friends, Dr. Shah and Dr. Rosen. So let's see here. Okay. So I think, I'm not going to go through an exercise in describing the technical details of resection, but I do want to discuss some of the recent developments that happen in cholangiocarcinoma that may actually push resection and its other treatments perhaps over the finish line compared to transplantation. I think what's happened in the last 5 or so years has been the development of adjuvant therapy for biliary tract cancers, certainly hepatic arterial infusion, and now triplet chemotherapy for advanced disease, as well as the molecular profiling and its associated targeted and immunotherapy components to it. So let's break it down by hilar cholangiocarcinoma first. So if we were to look at some of the large series, certainly here in the United States, this is one that I was involved in when I was a fellow at Sloan Kettering. And you can see this is using the Bloomgard staging system, 380 patients that were evaluated as a whole. And you can see the patients that did undergo resection, which was not all of them, obviously, did have a 5-year survival of 37.5% and 39-month median survival. And you can see that depended on their preoperative T stage, depending whether it was T1, T2, or T3. When you look at the actual survival curves, you'll see that the biggest determinant of survival was the margin negative resection, which was achieved in 120 patients. But that came at a cost of a mortality of approaching 8% and a morbidity of 60%. Well, let's jump to the adjuvant trials that were not around at this time. And so you can see here, starting from left to right, are the SWOG S0809, the BCAT, the PRODIGE, and the BILCAP. Starting with the SWOG trial, which was just a single-arm trial, but did have a significant proportion of extrahepatic biliary tumors, including perihilars. It did meet its endpoint, which was a 2-year OS of 65%, which is actually an enviable number. We move on to the BCAT and the PRODIGE, which also were a mix of all biliary tract cancers. And unfortunately, both were actually negative trials. Lastly, with the BILCAP, which was the only phase 3, and I'll say positive under quotes, in that it did show a per protocol analysis of increased survival with capecitabine versus observation. Although you'll note that perihilar tumors were the minority of those tumors that were included. So here's the actual data from the 0809 trial. Again, mixture of extrahepatic cholangiocarcinoma as well as gallbladder cancer. And you can see that the survival curve did not make a difference whether it was R0 or R1. This is the survival curve for the BILCAP trial, capecitabine median OS of 51 months versus observation of 36 months. Although again, the hazard ratio was positive only after the sensitivity analysis. But this is now considered the standard of care as of June 2017. So what about liver transplantation for cholangiocarcinoma? I was fortunate to actually listen to Dr. Rosen's lecture earlier, and he obviously has had, probably the most experience in the United States as well as potentially abroad. It is an option for locally advanced unresectable tumors. He did go over his strict criteria, which I'll not repeat, but it is limited somewhat by the tumor biology and certainly by graft availability. I think there's been some renewed interest in intrahepatic cholangiocarcinoma. However, the early experience was really abandoned because of poor outcomes and recurrence. This is probably due to poor patient selection. But I think the biggest challenge it faces right now is that there's no clear criteria for patients who should undergo transplantation. So again, this is the original Mayo Clinic protocol that you can see was quite involved. It included radiation, external beam, brachytherapy, chemotherapy, operative staging until you get the transplant. So it wasn't a new concept. So this is some of the original papers that looked at liver transplantation for hilar cholangiocarcinoma. And you can see the recurrence rates were high and the survival rates were not as promising. And so the question was, should this be pursued? I think in 2005 was really the first significant publication in the Annals of Surgery that looked at, again, transplanted versus resected patients. And you can see here now we're approaching a 5-year survival of 82% compared to the resection survival of only 21%. But if you actually look at the characteristics of those patients, there were significant differences. So certainly the transplant cohort had earlier stage disease, node negative disease, and only just slightly half of patients had a histologic diagnosis of cancer. And so we're really comparing sort of apples to oranges in this population. So this was the initial, again, experience I think Dr. Rosen had put earlier. This is in 2009, looking at the survival. And this is what it is in 2012 when it was last published, looking at, again, the difference between de novo disease as well as PSC. And as he clearly highlighted, the survival in PSC-associated cholangiocarcinoma is much better than the de novo cholangiocarcinoma. And we'll get back to that in a second. So what about patients with potentially resectable disease? So I think this is actually the key paper by Chris Kroom, also from the Mayo, looking at, again, their collective experience of resection versus transplant. And so again, if you look at the surface, it looks like the transplant cohort did better, although you can actually see the survival curves already crossing right around 20 months. But again, let's look at the characteristics. So you'll see between the resection and transplantation cohort, the resection cohort has significantly worse features. So there were obviously that 38% that had positive nodes. There were significantly a more percentage of patients with poorly differentiated tumors. And again, this makes you wonder if the patients that you're seeing that get transplanted are obviously selected better for that treatment. And in fact, when you actually plot out the curves of survival between transplant and resection in R0, N0 patients, they're completely superimposable. So again, trying to compare equal cohorts. They did do another analysis also on an intention to treat basis, looking at patients who had undergoing a planned resection versus enrolled in the transplant protocol. And again, this is an interesting survival curve to look at because when you look at it completely overlaps, although it has a statistically significant p-value. I think what's important to take from this paper is that these procedures are mutually exclusive. So you can't cross over from one to the other. So that in the resection cohort, 30% of patients were found to be unresectable, And in the transplant cohort, 60% of patients were not transplanted. And so you really have to choose a priori which pathway these patients should go. Although again, the conclusion from this paper is that patients who are even borderline resectable should be at least evaluated for liver transplantation. This is another interesting retrospective paper. This is from the US Extrahepatic Biliary Consortium. This is actually data that does not include the Mayo Clinic patients, but it's 10 different universities. And they did an extensive analysis, again, trying to compare transplant versus resection. And again, looking in that selected population of non-PSC transplant patients and resected patients that had small tumors, less than 3 centimeters, that would be qualified for transplant with N0 disease. And you can see that there seemed to be a slight advantage in the transplant population, although the numbers are quite small. There was two very nice accompanying editorials to this paper by Dr. Nagino and Dr. Rosen, and I had a chance to track them down at our cholangiocarcinoma meeting in Thailand. And it was very interesting to see their commentary. I think Dr. Nagino's point was that perhaps the surgeons in the US were not as aggressive, and that if those patients were in Japan, they might have had more resected candidates. And Dr. Rosen's very mature point was that even though there may be a slight advantage to transplant, the difference was not large enough to justify the organ allocation. So I think they're still trying to find a middle ground in this disease. Recently, there was a systematic review and meta-analysis comparing liver transplantation and resection for cholangiocarcinoma, and you can see the papers that were listed there, including the Kroom paper, as well as the Athune paper that we just discussed. And again, we're not going to go into the details of the forest plots, but I think the conclusion is also summarizes what the level of evidence is. And just to say that given the scarcity of available organs and the lack of true level 1 evidence, it really remains unclear whether liver transplantation should be increasingly considered for resectable early stage cholangiocarcinoma. What about intrahepatic cholangiocarcinoma? So again, looking at what the resected series demonstrate, this is again coming out of Sloan Kettering in 2008. Only 32% of patients that presented with this disease were actually able to make it to resection. And what happens even after resection? Well, there's a significant recurrence rate. So it's about a 60% recurrence rate at 2 years, and the majority did involve the liver. We do know some predictive factors, including number and size of tumors, as well as positive lymph nodes, vascular invasion, and a need for a bile duct resection. This is the actual survival curve showing, again, a median survival of 36 months following resection, which is much better than for patients who did not undergo resection. Well, what can we do to improve those outcomes? Well, I think there's been significant experience with hepatic artery infusion and colorectal liver metastases. And the reason for that is that chemotherapy can be delivered straight to the hepatic artery and to the tumor itself. It does require an operation and placement of the catheter into the GDA, and also ensuring bilateral perfusion in the liver and no extrahepatic perfusion. This was the early experience, again, in unresectable patients between hepatocellular carcinoma and intrahepatic cholangiocarcinoma. And you can see, at least in this small cohort of 26 patients, there was a significant partial response or stable disease. And these patients had bad prognostic features. 21 had multifocal disease and 11 patients had portal involvement. But there was not only an enviable survival of 29.5 months, but even 1 conversion to resectability. This is their updated experience now with 236 patients that had unresectable disease, of which 104 had liver confined disease and 78 had hepatic artery pumps. You can see the survival there is improved, or at least associated with an improvement over systemic chemotherapy alone, and 8 patients were converted to resection. Their most recent experience was actually published in JAMA Oncology in 2019, along with Washington University. And again, these are patients unresectable disease given hepatic artery infusion, and this time systemic GEM-OX, at least in this protocol. And they had a median overall survival of 25 months with a 1-year survival of 90%. So again, improvements from the initial experience. We actually have taken this approach and started our own intention to treat trial. This is by Dr. Sky Mayo, my institution. And so we're actually using a protocol now giving patients FOLFIRINOX systemically prior to pump placement, which then happens at about 8 weeks after FOLFIRINOX. And then they get adjuvant FOLFIRI afterwards. And so we're going to try to look at the objectives here is how can we deliver modern chemotherapy to these patients along with hepatic artery pump, and then actually have the data to collect quality of life, blood collection, and tissue. So this just opened actually this week at OHSU. We have 6 patient safety run-in, and we'll accrue 24 patients afterwards. So what about neoadjuvant therapy? I think that's probably a lot of the success in the Mayo Clinic high-level cholangiocarcinoma experience was the fact that they get neoadjuvant therapy. And in fact, if you ask Dr. Rosen what he thinks the role of transplant is that it's really adjuvant transplant. The primary therapy is actually the chemotherapy and the radiation. And where do we get this rationale for intrahepatic cholangiocarcinoma? Well, there's retrospective data. This is from France, looking at folks who had chemotherapy with surgery appear to have an association with better survival than surgery or chemotherapy alone. We do know that there's a new regimen that's available, the GEM-CIS nab-paclitaxel, which is Dr. Schroff's regimen, or GAP. This was the initial phase 2 experience with the Mayo Clinic, showing a significant waterfall plot with many patients having at least a partial response. And in fact, 12 patients that were initially unresectable were actually converted to resectability, of which 8 were intrahepatic cholangiocarcinomas. 2 patients even achieved a pathologic complete response, and a 3rd patient treated off protocol also had a path CR. This is the actual phase 3 trial comparing GEM-CIS Abraxane to GEM-CIS, which is the ABC standard of care. This trial accrued 268 patients in just over 2 years, so it's completed. So we should have those results and perhaps a new standard for advanced disease. But before waiting for those results, Dr. Maythel and I, my colleague, have embarked on a neoadjuvant therapy trial for these patients. And so these are a trial that we're currently enrolling at 5 centers in the US, looking at locally advanced disease as defined by large tumors, multifocal disease, major vascular invasion, and lymph nodes. And so we're almost completed accruing these patients who are getting the GEM-CIS Abraxane and then resection. Well, what about the genetic landscape? I think the other important piece of this is we've been selecting patients for surgery or transplant based on pathologic features, but we do know that the mutational landscape is quite rich, especially for intrahepatic cholangiocarcinoma, where you have about a 50% actual mutation rate. So mutations matter. We've had 2 recent trials with both the Clarity, looking at IDH mutations in the 2nd-line setting using a targeted agent called ivosidenib that did have not only a PFS benefit, but also an adjusted OS benefit. There was crossover, so it's hard to interpret the overall survival curves. And the FIGHT 202 trial looking at pemigatinib for FGF fusions. And you can see that the cohort A, which had the FGFR fusion, had a median OS of 21 months as 2nd-line therapy. So again, a promising strategy. And lastly, immunotherapy for those patients that qualify. So this is the original Dong Lee study looking at mismatch repair. And folks who did have a mismatch repair with immunotherapy did have significant responses. Although the issue with cholangiocarcinoma is that not many patients actually express that defect. And so this is in the latest Keynote 16 and 158 trials, it was really a handful of patients that had this. However, one of my good friends, Melinda Bikini, who was actually featured in the New York Times, who's had intrahepatic cholangiocarcinoma that was resected and then recurred with metastatic disease, was one of the first ones to undergo immunotherapy at the NCI with Dr. Rosenberg, looking at mutation-specific CD4 T cells. So this is the original Science publication in 2014. And she has had this disease for 10 years and is currently alive and well with her immunotherapy. So just to give a quick update, I'm sure Dr. Sapososhian will cover this. This is I think probably the best experience for liver transplant for intrahepatic cholangiocarcinoma. This is from Carrie Lunsford and the group at the Houston Methodist, which looked at a neoadjuvant chemotherapy protocol, looking at GEM and a platinum agent, and then having disease stability for at least 6 months before consideration of transplant, including then adjuvant therapy depending on the pathology. So again, small experience, 21 patients, of which 6 were ultimately transplanted. And you can see patients dropping off, just like in the hilar cholangio scenario. And here are at least the early results. And so I think there's been some winners in this. There's certainly a handful of patients that have had at least a greater than 5-year survival. However, there's also been patients who have recurred and also died of their disease. So I think in summary, hepatectomy is still probably the best option for resectable disease. I think our adjuvant therapy is somewhat effective and getting better. We should be doing more genomic profiling to see if patients are candidates for targeted immunotherapy. And keep in mind that even though that population is small, the immunotherapy patients really have some dramatic responses. And then I think as we improve systemic therapy and even pump therapy, these may be other options in our toolbox of downstage patients for surgery. I do think transplantation does play a significant role, and I think that should always be in the back of our minds. And certainly in hilar cholangiocarcinoma, unresectable patients and those with PSC should go to transplant directly. We may get there with intrahepatic cholangiocarcinoma, but we'll need to be highly selective in those patients. I'd like to thank you again for your time and look forward to Dr. Sapososhin's lecture.
Thank you, Dr. Roca. That's an excellent talk. We'll take questions after Gonzalo's talk. So let me invite Gonzalo Sapososhin, who's the Assistant Professor of Surgery, Abdominal Transplant and HPV Surgical Oncology at Toronto General Hospital at University of Toronto Health Network. Gonzalo, floor is yours.
Thank you very much, Ashish. Thanks for your invitation, and thanks for the organizers. It was great to hear Dr. Rocha's talk, and I think it's a great introduction to what I'm gonna try and point out. And I think we actually, even though this is a debate, I think we're gonna come up with a lot of shared ideas. Okay, let me see if I can. These are my disclosures, but these are actually my real disclosures for this talk. I think it's very important, as Flavio mentioned, that most studies that analyze transplant are in patients that are unresectable, and most studies that analyze resection are in patients that are resectable. And then it's going to be difficult to compare these two cohorts without comparing apples to oranges. And obviously, I am an HPV and transplant surgeon, so I do resect perihilar cholangio routinely. I think more importantly, Flavio and I share, soccer fans. I'm a real fan of Real Madrid, and we've had lots of Brazilian soccer players during the years. So I think that's going to make this discussion very easy. So these are a little bit my topics I think we can debate. Why transplanting unresectable perihilar cholangio and when? I think more controversial is why transplanting resectable perihilar, is there any role and when? And then finally, why transplanting intrahepatic cholangiocarcinoma and when? So transplant for unresectable perihilar cholangio, I think the big question, and it's a matter of debate on its own, is what is unresectable? And I think what is unresectable for Dr. Naguino is probably different to what is unresectable for me. But I think we can agree that probably unresectable is in patients with primary sclerosing cholangitis, as was already mentioned. What about involvement of the contralateral artery? And we'll talk a little bit about resection of the contralateral artery. And then probably invasion of the third and fourth order bile ducts bilaterally. This is the Mayo protocol, and I think Dr. Rosen already explained, so I'm not going to go through it, but we have a similar protocol in Toronto than the Mayo protocol, and these are patients that have an appearance stricture, a high CA19, and I think it's very important that the tumor is less than 3 centimeters in radial margin. They have to be above the cystic duct, as discussed before, and they have to be obviously this question of unresectability. Obviously, these patients undergo a very thorough neoadjuvant chemoradiation, and I think Dr. Rocha actually already mentioned, which I think balances a lot with this talk, about a lot of new therapies in this setting. And I think one of the issues with the Mayo protocol is that the therapies used were the standard of care, but I think that may be changed in the future years, both actually in the neoadjuvant setting and also in the adjuvant setting. This is a Mayo Clinic experience, and again, this is data that Dr. Rosen already showed, but I think it's important to assess again that on an intention to treat, so this is patients when they start their protocol, the 5-year survival in PSC is 60%, and the 5-year survival in the novel tumors is 40%, and this goes to 52 and 32, and those that actually get transplanted have a pretty impressive 5-year survival, both in the PSC and in the novel tumors. So why I think transplant is unresectable? Well, I think the outcomes, even though there hasn't been a randomized controlled trial comparing to gemcitabine cisplatin, which is the standard of care, I think the outcomes are probably better in unresectable perihilar cholangiocarcinoma, achieving 70% 5-year survival and 60% 10-year survival in some patients or selected patients. Again, this is with a very strict selection criteria. So these are small tumors. Obviously, there's no extrahepatic disease, and these patients undergo chemoradiation protocol. So I think more controversial will be the question about transplantation for actually resectable perihilar cholangiocarcinoma. And I'll try and give you some ideas of why this may be an option in resectable perihilars. I think one of the problems with resection of perihilar cholangiocarcinoma is the high rate of R1 resections. And this is just a summary of several cohorts. There are multi-center, single-center studies around the world. And as we know, the R1 resection has been, reported to be as high as 30–40%. Obviously, there are centers where it's lower. But even in the BuildCap trial, which Dr. Rocha mentioned, there were several hilar cholangiocarcinomas, and that's a prospective randomized controlled trial with very good data collection. The R1 margin is high, and I think most of the people in this discussion know that is a reality in this disease. I think the other problem with resection of perihilar cholangiocarcinoma is the high morbidity and mortality with resection. And we also know, and it's been well defined, that the mortality can be up to 10%. Obviously, the series have improved over years, and these resections in general should be done in very specialized centers. But still, I think it's one of the most morbid and higher postoperative mortality of the operations we do as transplant and hepatobiliary surgeons. And we can discuss that and what is the comparison with transplantation. There's actually a paper that will be published in the next years, in the next months, that Clavien started, and we were part of it, with 700 resections for perihilar cholangiocarcinoma of very highly experienced centers, and still the mortality in that cohort is relatively high, the post-operative mortality. And what about the outcomes of resection? Well, I think the outcomes have already been shown, but the 5-year survival of these patients, goes anywhere between 20 and 40%. And I think one thing that's important, and we can discuss, is that most of these studies, or all of these studies, don't include intention to treat data in the resection arm. And we all know that these patients get into trouble with tubes, cholangitis, some need to have a PVE, they don't grow enough. And there's no good analysis from the time of actually decision to make resection. So actually, if we did an intention to treat, probably these outcomes may be even worse. And we can discuss that at the time of discussion. This paper was already presented by Flavio, so I won't go in detail. But again, this is just trying to compare transplant with a cohort of resections that were in patients that could have been transplantable. Obviously, the key here is that these patients didn't undergo neoadjuvant therapy, but suggesting that maybe in that population, transplant has better outcomes. What about resection of the contralateral artery? Because this is a question that comes all the time, and it comes all the time in my practice in Toronto. And it's, well, if we have a long cuff of, let's say, right artery, and we're going to do a left tricep, why don't we just resect the artery if it's involved in reanastomosis? And this is a large cohort of patients from Japan, just to show you that in cases where the artery was resected, the 5-year survival is 22%. Obviously, it's hard to compare this to the transplant population, but just to keep that number in mind if we're thinking of resecting patients with an arterial resection. I think the big question would be, or the big question is, are resectable patients better off with a transplant than with resection? And Eric Vivert in France, with a multi-center French study, has tried and answered this question. I think this study had a lot of trouble to enroll, but I think they haven't published the data. This is the Transfield trial, which is a randomized controlled trial, again, randomizing patients that are resectable to either resection or neoadjuvant chemoradiation and transplant. And obviously this study would answer the question we're trying to debate today. So why transplant in resectable perihilar cholangiocarcinoma, and when? Obviously this is controversial, but I would say that the outcomes may be better than resection. Again, resection generally does not account for intention to treat. And obviously this would be in small tumors where, only within a chemoradiation protocol, and, discussing if we should be resecting the contralateral artery or not. So I will finally talk a little bit about intrahepatic cholangiocarcinoma and when and transplant in this setting. Again, Dr. Rocha already showed some of the study. I'll just show you some updated data This is this study that was published now in 2018 by the group of Houston Methodist and MD Anderson. And again, this is a very well-established protocol of patients with intrahepatic cholangiocarcinoma, biopsy proven. They undergo very strict neoadjuvant chemotherapy, in general with standard of care gemcitabine and cisplatin, but in many cases they actually got second-line therapies, and if they were stable, they were included in a transplant protocol. 12 patients were listed for transplant, and in their initial paper, they published 6 transplants. They've actually transplanted, I think, another 6 patients, and the outcomes are as follows. So this is a cohort of 9 patients when they had transplanted 9 patients. Again, as Dr. Rocha mentioned, some of them have had recurred, but I think going back to the idea of the colorectal liver metastasis and transplant, one patient recurred early in the lung, and looking retrospectively, this was a already found lesion, and it was already there but difficult to characterize, and that patient had a lung resection and is alive 5 years after. Other patients don't have enough follow-up, but certainly this is exciting, and it's an exciting new arena, especially as Dr. Rocha mentioned, with the new therapies coming up. We will probably be sequencing these tumors at the beginning, and some will get targeted therapies, and maybe if they have amazing responses, we could go ahead and transplant them. I think it's also important to say that in this study, most patients had multifocal intrahepatic cholangiocarcinoma. These were large tumors, and again, the results are exciting. We obviously need to validate this. We're doing our own trial in Toronto. So why transplant for intrahepatic cholangio, and when? Well, I don't think this is a trial for resectable intrahepatic cholangio, so patients with single intrahepatic cholangio should be resected, but maybe it's a good treatment for multifocal intrahepatic cholangio, obviously without extrahepatic disease, and after good response to chemotherapy. And I think it's important to remember that most of these intrahepatic cholangio, after we resect them, 60% recur in the liver only, and that may be the population where transplant may help. I would just like to finish to tell Dr. Rocha that actually he doesn't know, but my family, I know my family is Argentinian, so I would like just to finish my talk with this video, and I look forward to discussing now. Thanks.
Excellent talk, Gonzalo. Chairpersons and Flores can ask the questions. Dr. Halazoun has sent his question, though he's operating right now. So if you don't have any question from the chairperson, I'll start. His question, Dr. Rocha, for you: should transplant surgeons be in every liver tumor board to advocate for these patients? Because otherwise they will shunt it to destination chemotherapy for intrahepatic cholangiocarcinoma, considering the results shown by Gonzalo. What's your take on that?
Yeah, I think absolutely. I've actually, this is since my move to Oregon is actually the first institution where I've had the pleasure of having liver transplanters in my department. I was at the Memorial, which didn't have liver transplant. I was at the Brigham before that, and then Virginia Mason. So we always have to externally look for transplant surgeons. But no, I think probably the best, I wish I had the slide from Dr. Rosen, which shows 2 otters who apparently, they sleep holding hands together. So I think that's what I'd like to do, is have us all at tumor board holding hands.
All right. Gonzalo, it's for you. How much stability of disease you require before the transplant?
So I'm guessing that question is mainly for intrahepatic cholangio and
Correct.
For the protocol. So yeah. in the, interestingly, in the Methodist MD Anderson study, when you look at the time from diagnosis, most of these patients had been waiting for at least 16 months. In our protocol, given that we're only doing living donors and we don't want to expedite these patients to go too fast to transplant, we require 9 months of stability on chemo. And then we start working them up, which at the end of the day would be a year from the time the treatment, it may take 2 months until we find a donor, et cetera. So around a year for transplant, but 9 months of stability before we actually start the living donor liver transplant workup.
All right. Dr. Rocha, it's for you. How do we justify destination therapy chemo when we know patients will do better with transplant, with multifocal cholangio, considering this evolving data on that in intrahepatic cholangiocarcinoma?
Well, I would kind of push back a little bit on that, saying that I'm not sure we know that transplantation for intrahepatic cholangiocarcinoma is the panacea. In fact, if you look at the initial experience, it was actually quite poor. And in fact, I think even Gonzalo suggested it in some of his editorials that perhaps we should look at the early stage resectable small lesions, because those patients had the best outcomes of transplantation. So I think, to be honest, the best strategy is perhaps a combined one where you do get the genomic profiling data, you do have that period of stability, and perhaps consider transplantation in those patients that have a favorable mutation profile. But curious to hear what Gonzalo has to say about that.
Yeah, I think that's a great point, and I actually completely agree with Flavio. I think with more information we're getting, I mean, every patient that goes into our protocol gets a biopsy and gets sequenced, or should be. We have some, we're not as fortunate as Flavio in the US, but we're trying to sequence every patient. And yeah, I think that's completely where this is heading with all the new therapies. And I think it's very exciting times to come. And I think that's going to be the key, to treat these patients targeted with whatever we can. And then, yeah, I think if there's a period of stability, reassess, the question of transplant. And going back to the first point that Karim had, I think it's important to somehow, and I think this is happening, and I think Flavio is one of the people that is helping for this to happen, is to educate oncologists that if they see these amazing responses, these patients need to go back and see, a multidisciplinary tumor board where there's transplant surgeons, at least to discuss this option.
First of all, congratulations to both the speakers. My question is for Professor Gonzalo, that what is your take on transplant for intrahepatic cholangiocarcinoma with a small SOL in the liver, 2 centimeter SOL in the liver? What is your take on transplant?
Yeah, so I didn't bring this question up because I think that is a little bit of a different population. The research we've done in that arena is obviously on cirrhotic patients. These are cirrhotics that have, very close surveillance, as hepatologists do surveillance every 6 months. We find these nodules, and we're seeing more and more that there's a French study that just came out that shows the same thing. We're seeing more and more that these tumors don't have the classical features of hepatocellular carcinoma, and we biopsy them, and they're actually adenocarcinomas and they're cholangios. Our data has, shown in 2 medium-sized retrospective cohorts that those that have less than 2 centimeter tumors do actually very well. And I think that the bottom line is that those patients that have a biopsy and there's a small single less than 2 centimeter adenocarcinoma probably have a very good outcome with transplant. We're doing a prospective trial, which is being a bit of a nightmare to accrue for many reasons that I think are beyond this discussion. But I think those patients are the ones that may do very well. But I think we need to distinguish cirrhotic population from non-cirrhotic population. I think there's distinct features in those patients.
Yeah, and I would agree. I think that's, and I thank you, Gonzalo, for bringing that up. I mean, certainly, a small lesion that's resectable in a good liver, I would resect, but certainly I would have pause in a cirrhotic patient. I would ask you though, I mean, is the benefit that you're seeing in those patients because you're improving their liver disease, or because it's truly an oncologic improvement? Because you may, a small 2 centimeter tumor in a cirrhotic, you may be able to ablate if it's in a good location. And I don't know if you've compared that outcome, ablation versus transplantation.
So that's obviously an excellent point. I think the data from ablation that's coming out, there's a couple of papers. There's one actually from the BCLC in Barcelona, and the outcomes are not that good. And I don't have an explanation of why we ablate HCC and they do so well, and we ablate cholangio and they don't. But the reality is that sometimes as surgeons, physicians, we try and extrapolate. And I don't think you can just say, well, because this tumor is small, we just ablate it. And I think the same is true in colorectal liver metastasis. I mean, we know that the results of ablation in colorectal liver metastasis are not the same with HCC. And I don't quite understand the biology, because I think, well, we're killing the tumor with heat, but they're different. So I think we haven't had the opportunity because there's not enough patients to compare that. It's a great point. I think what's more challenging is that with laparoscopic liver surgery, we're obviously pushing the envelope on resecting patients that are maybe Child's B, may have portal hypertension, and that's where it gets tricky. Should we transplant those patients or push the envelope with, for example, laparoscopic liver surgery? And it's a difficult one.
Alejandro, you are up.
Can I ask one? Yes, I can. Sure. I have a question from Gonzalo to Gonzalo.
if in the Eric Weaver study trial, you can see that their radiochemotherapy, neoadjuvant radiochemotherapy in the transplant group, but only in the resected group, no neoadjuvant radiochemotherapy. And similar with the pancreas cancer, now there are several open studies with neoadjuvant in resectable pancreas cancer. Do you think the neoadjuvant radiochemotherapy in the resected group improve the results in this group in comparison with the advantage in the unresectable but transplantable perihilar cholangiocarcinoma?
Yeah, I think that's a great point, and actually, I think Flavio, explained this beautifully. I think that's probably where resection is going. I think we're seeing more and more in HPV tumors that neoadjuvant therapy is the way to go. However, I think many people in this call may have been trying to resect a patient with previous radiation, like a hilar cholangio. I think we need to be a little bit careful, and that's why there's no crossover. Trying to resect a patient with real, radiation in the hilum, it's you can get into a lot of problems. But the bottom line to your question is yes, for sure. I think that HPV surgery is moving more and more to neoadjuvant therapies. We're not there yet, and I think all these studies are the ones that are going to answer some of those questions.
Yeah, and I would agree, Alejandro. That's a great question because, again, all the data that we talked about with resection is surgery alone. So no preoperative therapy, no postoperative therapy. So again, we're comparing two different populations. Now, for intrahepatic cholangiocarcinoma, it's easy to get a tissue diagnosis. The challenge for perihilar, and I was actually brought up by Dr. Shaw in the previous session, is you can't get a positive biopsy to justify the chemotherapy. And so I think that's the challenge in trying to give neoadjuvant therapy for perihilar disease.
Another question will be in intercholangiocarcinoma recurrency in this 60% group, when you evaluate the recurrency patient to transplant.
So again, I think that's another great point, and I don't think we're there yet. I think there's been some papers on re-resection, but again, I think that we've seen this with HCC too, right? If you have a patient that you've resected an intrahepatic cholangio, let's say 2 years ago, recurs with 4 nodules in the liver, you start them on GemCis, they're stable. A year later, you do a PET, there's no extrahepatic disease. Listen, maybe that is the population that actually is going to do well with transplant, but I don't know the answer to that. I think this is completely speculative.
Yeah, I'll bring up, it's pretty rare, I think, that scenario that I will re-resect a recurrence, but I'm starting to have now a collection of patients that have been on, I have one, for example, who's a mismatch repair deficient, had a recurrence after resection, is on immunotherapy for 2 years, and the lesions responded. They're still there on the films, but they're not growing. He's tolerating the immunotherapy. I just said to sit tight and let's just wait and see. Now, unfortunately, that's going to be 1% to 2% of patients. But again, if you hit the genetic lottery, that may be the way to go.
All right, guys. In the interest of time, we need to move to the next session. Thank you, all the chairpersons. Thank you, Dr. Flavio and Gonzalo. All right.
Thank you.
We need to move to the next session on panel discussion. The topic is resection versus transplant for benign liver tumors. And the moderator for the session is Dr. Roberto Alejandro. He's a professor of surgery. He's the chief of in Division of Transplant and HPV Surgery at University of Rochester Medical Center in the United States. He's a chairman of Education Committee in LTS. Roberto, floor is all yours.
Thank you very much. Thank you for the introduction. I will need that someone disable the screen and allow me to share the screen for the case presentation. In the meantime, I just want to say thank you very much for this invitation, and especially Ashish for being in this part of the international conference. I would like to introduce the panelists that we're going to have today. Those panelists are Professor and Chairman Orlando Jorge Torres. He is from the Department of HPV and Transplant Surgery of Marajao Federal University in São Luís, Brazil. Dr. Alan Contreras, a very good surgeon, great friend, also HPV and transplant surgeon. He's the surgical director of liver transplantation in Salt Lake City at Intermountain Medical Center. Also, we have two local surgeons that they're with us today, Dr. Metu Reddy. He's director of liver transplant and HPV surgery of Guineagles Global Hospitals in Chennai, and Dr. Abhishek Yadav. He's director of liver transplantation in BPS Lakeshore Hospital in Kochi, India. So with this, I would like to start my presentation. Can everybody see my presentation? Can you see it?
Yes.
All right. Okay, so I was asked to give this presentation on benign tumors, whether it's resection or liver transplantation, a complex topic. And I think Ashish put the bar very high, and hopefully this is entertaining. And let's start with the first case. So this is a patient, female patient, very young, very healthy, as you can see with her BMI, and she's a sport person, and she fell during snowboarding. And 2 days later, she had a lot of pain, and especially in the back and in the shoulder. She was already home after snowboarding, and she went to her community hospital, where they did some studies, and they found that her hemoglobin was 8.2, the CREAT was 26%. They did a CT of the chest and abdomen, and they found that there was free fluid and what appears to be a liver trauma. So this patient went to the operating room in the community hospital, and they said that there was ruptured liver tumor. The patient required multiple blood transfusions during the operation, and since the beginning, they did damage control operation, and they packed the patient. They didn't resect anything. The patient has a prolonged length of stay because the abdomen was open. She has 3 returns to the operating room with lavages. She has some infections. They have to put some drains. So I'm sharing this video, and this is a video that I was able to retrieve from the center where she went. And as you can see, there's some drains already there. You can see it's not the ideal CT scan, but this is what we have. And you can see that their abdomen was open, and there's drains and a large mass. They're kind of in the center, and some gas already. Okay, so no questions so far there. And then the patient recovered from the laparotomy and from the bleeding. And 4 months later, she was referred to a hepatobiliary surgeon. And this is a CT scan 4 months later. Pretty different. As you can see, there was some abnormality in the abdominal wall here. I didn't see anything really bad, just that area where apparently there was the rupture of what appears to be an adenoma. Okay, and now what? The question is, now what? What would you do if you are that surgeon and they refer to you? I don't know if let's ask Dr. Reddy. Dr. Reddy, are you there? Can you? Or Dr. Contreras, Alan?
Yes. First of all, thank you for this invitation to participate. It's a pleasure to be part of this panel. Well, this is a very particular situation because we're talking about a lady that had a trauma. We know adenomas are very dependent on hormone stimulation. So if I could see this patient for the first time without the background that she had trauma, I would probably advise, if there is a lesion in the CT scan, to stop any kind of hormonal replacement therapy. the possibility that this adenoma is gonna become something really bad is very low. So I would just talk to the patient and follow her. Having said that, this lady came to you referred because of this abdominal trauma, and she have had multiple surgeries. So it's kind of a different situation, but just talking about the adenoma, I would just follow her. Yeah.
All right. Anybody, Dr. Orlando, Dr. Reddy, or Dr. Jadab, would you do something different of what the parobiliary surgeon? The parobiliary surgeon saw that imaging similar of what Dr. Contreras is mentioning, no much abnormality and just observation. Anybody do something different at this moment?
No, I think the best thing would be to just observe her. She's recovered from quite an extensive treatment regime, and the CT looks good. So as long as she's clinically well and liver function tests are normal, I wouldn't do anything actually.
All right. So patient after the patient left the HPB surgeon, the patient didn't have too much follow-up. She was feeling well, and later on, 4 years later, she had some abdominal pain, and the PCP, the primary care physician, saw the patient. They did some imaging and they sent it to our institution, and this is what we see now, 4 years later. Large mass in the bottom part of the right lobe with other multiple masses involving the hepatic veins, as you can see. This is a CT scan, this is an MRI, this is a coronal. Just to give you more information, you can see that large mass around 10 centimeters with multiple here. Seems that the left side is small, but we cannot see any other abnormality, probably there in the top of the left hepatic vein. So now what? What would you do different, Orlando?
Thanks, Roberto. The left hepatic vein is involved? If not.
No, it's not involved. You can see that.
You have to see the volumetry in the left lobe and to do resection in this case. If you have the right hepatic vein involved, you should resect the patient and keep only the left hepatic vein.
So you will do directly for resection. You wouldn't do any other studies at this moment in this patient?
Because the volume is bigger than the first image.
Correct.
Yes, sir. Okay.
All right. Anybody do something different?
Well, I would just like to add that it's really concerning that she has these growing masses, because when we see patients with this benign tumor disease, very rarely we have a study prior to compare. And in this case, you show us a CAT scan done 4 years ago that was really not very relevant, and now we're having all these messes slowly growing up. So as I said before, if there are characteristics of adenomas, I would probably just look into any hormone therapy that she's taking just to give it a chance if they can regress, because we have seen regression when we stop these medications. The patient has any symptoms related to this, Roberto?
No, she just has some abdominal pain. The PCP did an ultrasound. The ultrasound showed masses, and then they did they sent it to us, and this is the MRI 4 years later. So from having something small, now she has many lesions, majority in the right side, probably too small in the left side. So now, knowing that this was an adenoma, we wanted to learn more about that adenoma, know more about the details on genetics of that adenoma. And the decision was to do a biopsy on this patient. As Dr. Contreras mentioned, the patient was not receiving any contraceptives at that moment because it was stopped since the first time. She was interested in getting pregnant, and we know that there can be some changes with pregnancy, so we asked gynecology to see her. And also she has a history of ovarian cancer, family cancer, and her mother died at age 42 after getting diagnosis with ovarian cancer at age 38. The biopsy shows that there's no expression of HNF1 alpha. So we know that this is one of the most common adenomas. This is not pre-malignant, apparently, and the rest of the tissue of the liver that they took a little bit of sample, it was normal parenchyma. The gynecologist finds some gene mutation on her, which increased the risk of ovarian cancer, something there probably from inherited from the mother. So the gynecologist said this patient needs to have oophorectomy soon. So we know that she has adenomas large in her liver. The gynecologist wants to do an oophorectomy. We know that she has that risk of ovarian cancer. Now, what would you do? Any point here, Dr. Reddy, Dr. Jadad?
But I think based on the CT scan, I would agree with Dr. Torres that I would suggest surgery. I think the remnant left-hand segment looks to be of good volume, and she's a young lady, so I think she would tolerate a right trisectionectomy reasonably well. I don't know what would we have found on the biopsy that would have changed our plan. I mean, is there something that you were looking for on the biopsy that would let you decide whether to resect or to transplant or to do nothing?
So that the main reason that the patient went for a biopsy is to rule out if there was some malignancy.
Okay. So, I mean, like I said, I think even if it's a benign adenoma, such large adenoma, she's already had one ruptured adenoma, probably due to trauma. I would suggest resection. In terms of the oophorectomy, you said that she wanted to get pregnant to have a pregnancy. So I think that's something that you need to discuss with the patient whether she would want to have a oophorectomy right away or wait until she gets pregnant and then go for it. But first would be the surgery. I would recommend liver resection for her.
Any other point here? Any other discussion? Any other different?
I do agree that am I audible? Hello.
Yes, Abhishek,
Hello.
you are audible.
Yeah. Okay. So yeah, I agree that I think that resection. I mean, from whatever we can, at least I can see on the CT scan, the left lateral lobe seems to be good enough, and I think extended right should be fine with her. Regarding the biopsy, adenomas are known to have. I mean, even if they develop a malignancy, those malignant foci are very they're very focal malignant areas in adenoma. So I'm not sure whether biopsy will be able to really representative of a malignancy, even if there is a focus of malignancy inside the adenoma.
Okay, sounds good. So well, this case was presented in the tumor board. Decision was made to the gynecologist decided this patient needs to go for bilateral oophorectomy. And we thought about consider embolization of their large lesion to decrease chances of this patient to have bleeding. She was asymptomatic at that moment. And of course, consider an extended hepatectomy, as you mentioned, versus measuring the volume, and even consider AILBS because there were two small lesions in the left lateral segment. So that was the decision. The patient went for oophorectomy. The decision was, and she was not going to get pregnant. And this is after that, they see a new MRI that is coming to show us the following. So if you remember perfectly, there was some parenchyma of the liver in the bottom part of the liver in the right side, and now there's minimal parenchyma in the right side in the inferior part. So we have the right, the middle, and then if you see now, I want to repeat it again, this one. I want you to concentrate in the left side of the liver, in the left lateral sector. You can see those lesions here, 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 the left hepatic vein here, another one here. So there's more there, and there's these big masses here. If we look to the coronal images.
Alberto,
yes?
The size of the tumor in that side is more than 5 centimeters? on the left side?
More than 5 centimeters? No. There's are
No.
very large here, and you can see again.
Only the left side.
That's correct.
Okay.
What would you do now? So the gynecologists, they mentioned that these lesions after oophorectomy, they will decrease in size. And that was one of the main reasons that there was holding between 3 and 6 months of time. And it went the opposite. They continue growing. So now the question is, would we do an AILBS or an extended hepatectomy, right hepatectomy, and leaving those 3 lesions or more lesions in the left side? They're gonna continue growing. Should we consider doing a liver transplantation in this patient?
Did you see the volumetry in the left lobe?
No, we didn't do volumetry on the left lobe.
No,
the right portal
very
vein is
concerning.
okay?
Excuse me?
Sorry.
Go ahead,
Because
Orlando.
Seems to me the left lobe is too small. If it's possible to perform like portal vein embolization in the right portal vein or AILBS in this case. And if possible to resect the small lesion in the left lobe.
So as you can see already, the left lobe is a little bit bigger than before, and I think this is probably with some partial compression of the right portal vein from the adenomas. The question is here now, she has more lesions in the left side. So this is yes, go ahead.
Okay, but I think I don't know how it's in the US, but I think in the Indian setting, if you are going to think of a transplant, it would have to be a living donor transplant for this indication. I mean, this is a case where you can be right both ways. You can say resect do a right resectionectomy, and maybe we can do RFA, intraoperate RFA for the lesions in the left side. But you would probably, we would say that if you have a suitable living donor and we can do a living donor liver transplantation, then that might be the best long-term treatment for this lady. So it all depends on how easy it would be to go ahead with the transplantation in her. That would be my discussion with the family.
So I think that comes a very important comment that you mentioned is about resources and capacity of the institution or the country to be able, here in our institution or in the country, this patient wouldn't be able to have exemption points in the MEL score. The MEL score of that patient was 6, so she wouldn't be able to attract a liver and waiting for a liver. So you're right, whether we do a live donor transplant or we do hepatectomy and trying to ablate the other tumors. We thought about doing an AILBS in this patient. We discussed it, and the decision with the family was to do workup for live donation, and this is what happened. So the patient, the median MEL score in my area is 33, so she wouldn't be able to attract the liver, and the patient went. This is representative imaging, pathology of the large adenomas, and finally the patient had live donor with a good graft, and things went pretty nice and smooth. So that's the story of this patient. What happened next? I think it's too early to say what is happening to this patient, but patient recovered well from this operation. Importantly is that we didn't know this, but in the pathology came back from the X-ray that there was a beta-catenin positive stains. So this is pre-malignant disease. So that was one of the adenomas that was in the right side. So I don't know if In adenomas, there could be some transformation or some mutations, but this is what happened in this patient. Any discussion, any comments here from Orlando, Alan, Metu, or Abhishek?
Yeah, hi. We see that this adenoma is growing quite ferociously in spite of the the oophorectomy and stopping the hormonal therapy. From what I remember, adenomas are known to be associated with a lot of storage disorders. So I was wondering whether this patient had been evaluated for one of those storage disorders leading to this aggressive adenoma.
Any more comments?
I think but was still asking if there is any evaluation for glycogen storage disease in this recipient. I assume probably not. What I'm seeing is like this patient is having adenomatosis, which is like a kind of the different and separate scenario that are not related to these genetical disorders. It was definitely, now we know that this lady has like a big catenin, but it was very concerning that we don't know why this lady is making such these tumors, and even that we have not the ability to categorize that now. We knew that this is a disease that probably was not going to be under control with surgery. My only point probably to ask, and I think that was a great decision to just do the liver transplant, because as I said, probably was going to be very difficult to have her disease-free with surgery. My only point would be, if doing like a surgery, or just trying to do a surgery first to be just delaying the transplant for the future could have been an option. Just trying to do a right lobectomy and ablate the lesions in the left lobe, trying to stall some time.
That's a very good point, Alan. And I have to be honest and clear here. In this case, I was pushing for doing surgery, resection, but the rest of the selection committee opted on pushing for live donation, especially because the family said we have potential donors and they have like 5 or 6 in the row in line to get it here. It ended with I think it was apparently the best decision at this moment, but we didn't know about this pre-malignancy. And I think the fact that this patient has some genetics mutations for ovarian cancer, the mother, and so probably there's something not common and not something a little bit more fishy in this patient. So we have to have a close follow-up on her. All right, can we move to the next case? So let's move. This is a man, patient, 50 years old, a smoker, BMI 27. The interesting part here, and I want you to think about it a lot, he is a Jehovah's Witness. No blood or other products. He was very clear, nothing can be used. Not even albumin on him can be used. It's known to have a liver hemangioma since 2012. And those are the measures. As you can see, there's a representative picture up there. And it was assessed by a liver surgeon in 2014. Observation and follow-up for 1 year. And that was the decision of the surgeon. So this patient came to see the liver surgeon and they said, well, they have this hemangioma of 9 by 5 centimeters. And it's completely asymptomatic. Everybody agreed of doing nothing, just observing and doing imaging in 1 year just to follow him.
Yes, follow the patient.
Okay, so this is 1 year later. The CT scan, that's a hemangioma. Clearly characteristics of the hemangioma. A little bit larger. Patient is completely asymptomatic. You can see the vessels, the portal vein. The right portal vein is just abutting, but it's not compressing. Would you do something now?
Symptomatic, Roberto?
asymptomatic, doing like zero.
In case of symptomatic patient and embolization, it's a very interesting option.
You will
suggest the
recommend.
embolized tumor. Yes.
All right. Yeah, Alan.
Roberto, is there any concern about the diagnosis? We are just seeing just part of the CT scan, but I would say that if there is any concern about diagnosis, I'll probably do an MRI just to complement the study. But if the diagnosis, if this is like a typical lesion for hemangioma and the gentleman is asymptomatic, I wouldn't do anything right now.
Okay. Yeah, there was no concerns about having other diagnoses, Alan. It was clearly a hemangioma that has been followed for years before, and the patient, it has been showing some slowly growing, but completely asymptomatic. So the decision was, all right, let's do another follow-up in 1 year. And this is 1 year later. Again, the same hemangioma. And when they measure it, it's a little bit more bigger, like 1.5 centimeters bigger, occupying part of the right side. Again, the left side is without any problems. And in the upper part, segment 7 and 8, perhaps 8 is a little bit taken by the hemangioma. Any changes? Would you do something different? Again, the patient is asymptomatic.
This is Dr. Vivek. So my question to panel is, why not resect? Such a huge tumor compressing on all the blood vessels.
The patient is asymptomatic, right? And this is a benign tumor without zero possibility to becoming something malignant. So it is hard to offer this to a patient. It's going to be a surgery. It doesn't matter if it's a small surgery, a large surgery in hands of people who have experience with that. This is still a surgery that has risks. And we know that benign tumors like this, the only indication is if they have symptoms. So I would still do the same. I will still just follow this gentleman.
Agree with Alan.
Orlando?
This patient, if you have a bigger than that one in asymptomatic patient, just to follow the patient.
Okay, well, I hear that someone said, would you resect it? So to my understanding, discussion was taken about resecting this patient. But the decision was finally to observe, as Orlando and Alan mentioned. And then in 2017, one year later, the follow-up was every year, not every 6 months. We can see again, probably the left side looks a little bit bigger of the liver, and the hemangioma again larger. This is the hepatic phase, as you can see here. We can see the artery. Sorry, that was the portal venous phase. I apologize for that. And this is the arterial phase. The patient has a left accessory, and that's the arterial. Looks bigger. 2017. So we have 3 years following this patient. The patient is now, I think, about 53, 54 years old. Would you continue doing something different?
I think,
Question
Yes.
to the panel. This is a large tumor going into Porta now, and I think I saw that patient was Jehovah's Witness. What's your take on if the spontaneous rupture on this kind of patients, and now taking such a big tumor for surgery?
Well, I can see why Roberto is presenting this case, because now we are all going to be in a dilemma. Well, if we keep just following this gentleman, until what point, right? What is going to be our threshold to do something about it? Because it keeps growing, and apparently it keeps displacing the vascular structure. So at some point, he may run into a problem. And he's a young man, so how long are we willing to wait? But the question you're asking, actually, is very relevant now, because it's not just the disease, it's the cultural and religious point of view that we couldn't give us all the tools we need to treat these patients. We know that hemangiomas can be easily resected if we just do isolation or we prepare in a way, but sometimes we run into trouble. Sometimes these patients bleed, and I understand now, Roberto said that he is not even willing to accept albumin transfusion. So I would definitely discuss with the patient what is going on. I don't think there is a clear answer here, but I think you are making a good point. This tumor keeps growing. So at some point, we're going to have to make a decision how far are we willing to wait or do something about it. But I don't know, let me just try to guess. I have the sense that if he continues with his beliefs that he doesn't want to have any transfusion, he will probably say, let us just keep waiting.
Can I make a comment? I mean,
sure.
We followed up this this chap for the last 4 years now, and every year it's increasing diameter by 1 to 2 centimeters, isn't it? I mean, it's just that now, obviously, an increase in diameter by 2 centimeters actually maybe even double the volume of the tumor. So, is this wouldn't be the usual hemangioma, which are slow growing tumors, and this has grown significantly in the last 4 years. Would at any point would you think, maybe this is not your usual hemangioma and maybe we should resect it, or what? Can we do anything else to see if this is something a bit more malignant as compared to a usual benign hemangioma?
So it was clear with all the imaging and the long follow-up that this was a cavernous giant hemangioma, and with, as you mentioned, with as like a continuous growing every year, there was showing some growth. The fact that the patient was completely asymptomatic, and more importantly, that the patient was Jehovah's Witness, the easiest thing to say is, we'll see you in 1 year with the new imaging. But every year he comes asymptomatic and then it's getting bigger. And I think Alan is touching a very important point. Would it be better in early stages to resect this patient, knowing that the patient will need to have minimal blood loss in these type of patients? So in having said that, this was the 3rd or 4th time the patient has a CT scan, and the patient didn't show up since 2017. 3 years later, came back. The patient never came back due to lack of symptoms, but the patient suddenly had fevers and chills, rigors. Patient was taking Tylenol, losing some weight, and I think this is a syndrome that sometimes you can see with these large hemangiomas. The primary care physicians in their community hospital starting antibiotics, and the patients say that they did imaging at that moment, and this is the imaging that they took at the community hospital and they shared with us.
Roberto,
yes.
Can we really wind up faster because we're running short of time? There are a lot of.
Sorry. Okay. So you can see it's larger, way larger, and this is the coronal imaging, which is getting bigger, getting bigger. The patient arrived to our center. It was transferred to the emergency department. We did an ultrasound, Doppler ultrasound. There was some compression and some thrombus in the portal vein, and now some decrease in the flow of the portal vein, as you can see here in the Doppler. Vascular compression, apparently in the artery, you cannot see the nice upstroke. And in some of the reconstruction with the ultrasound, you can see it's very poor, the flow there. This was some of the blood work, a little bit elevated liver enzymes. Hemoglobin was low. And then the plan was what do? We do a hepatectomy, we do some enucleation, we do some embolization, we do a transplant. What was the plan for this patient? So I know that we're on time. And the decision was, how can we lose less blood in this patient? We thought that if we do embolization in this patient, the artery is already partially occluded. We're not going to have too much benefit. If we do an ablation, this patient is going to require blood transfusions for sure. And hepatectomy, we thought that it will have a higher risk of having blood transfusion with hepatectomy than with transplant, because we will work around the liver in a patient, and decision was to do liver transplantation in this patient.
Well, the
Roberto,
the
I have a
evolution.
question. So
Go ahead, Darren.
Orlando. Sorry. You go first.
The evolution of this patient is completely different from all other kind of hemangioma. Because,
right.
Do you agree? In this
I
case,
go
if symptomatic patient now, my first option would be embolization.
Yeah,
What was the histopathology? It was hemangioma.
The pathology was a clear hemangioma, cavernous hemangioma, giant cavernous hemangioma. There was nothing more in this patient, no malignancy. So important to mention here is, I think this patient in conditions in early stages probably would be a better candidate when he was in better shape with higher hemoglobin, no other symptoms, to do liver resections in an early stages instead of waiting for 7 years in follow-up until there was some vascular compression.
All right, thank you guys. Thanks, Roberto. I know it's an interesting topic, but we're running short of time. You did a great job, and thanks to all the panelists for joining us. I'm going to move to the next session. It's an interesting video session. I would like to invite the chairpersons, Dr. Abhideep Chaudhary, who is a director of liver transplant and HPB surgery at BLK Hospital, New Delhi. Dr. Thiago Biduski, who is the chief of Division of Transplantation at University of Florida in Gainesville, United States. Dr. Ramesh Bhandari, who is a professor and unit chief for GI HPB liver transplant at TUTH Hospital, Kathmandu, Nepal. And unfortunately, Dr. Mahesh Goel from Tata Memorial couldn't join us. So I would like the chairperson to please invite the first speaker.
So for the next video session, our first speaker is Professor Krish Menon, who doesn't need any introduction.
Mi querido Beto, nomás faltó que nos dijeras que el donante también era testigo de Jehová.
Somebody needs to mute.
Yeah. So welcome back, Professor Menon. Professor Menon needs no introduction. He is a clinical lead, liver transplant surgery and HPB surgery, King's College Hospital. And recently he has been elected as president-elect for British Transplant Society and the president-elect for Great Britain chapter of IHPBA. Welcome, Dr. Krish. We are eager to listen to your video talk.
Thank you very much for the kind introduction, Vivek. I'll try and share my screen so we can get going. So, thank you. Can you see the screen well?
Yes.
Yeah. So thank you very much. And my topic today is on laparoscopic liver resection and cirrhotics. And when we talk about laparoscopic liver resection and cirrhotics, really what we are talking about is resection of primary hepatocellular carcinoma. And we're all familiar with the BCLC staging system. And we know that when we talk about resection, we're talking primarily about resecting early stage HCCs. What I'm going to try and do is to try and give you a bit more just than a video, a philosophy on how you approach patients who've got HCCs in the liver that are cirrhotic or got bad synthetic function, and try and give you a flavor on what are the tips when you operate on such patients, particularly in cirrhotic livers.
So when you talk about resection in early stage HCC, the resection rate can vary from unit to unit, how aggressive you are, 5 to 40%. The mortality post-resection, however, is with particularly cirrhotic livers with borderline liver function. And that's because they pose a risk of decompensation after surgical resection. Intrahepatic recurrences are also do happen in these patients. So you've got to be prepared that you might get a second tumor and you have a plan of management as to whether you're going to resect or you're going to offer them salvage transplantation. Distant metastases can occur, so selection of patients has to be really careful. Hepatitis, which is primarily one of the reasons why people get HCCs in the liver, have an associated lifelong risk of developing further tumors, and that can be as high as 50 to 70%, depending on how good your viral control is. Resection versus transplantation for early HCC, really what we're talking about is an algorithm that is dependent on the availability of organs. What is the degree of synthetic dysfunction in terms of the chronic liver disease? And what are your options in your particular unit of dealing with recurrence, particularly with salvage liver transplantation? However, for me, the key factor that helps you determine which route you go down is the presence of portal hypertension. And that's what tilts the balance towards liver resection or liver transplantation. What I'm going to allude to today is two important bits. One is, could the minimally invasive approach to manage early stage HCC influence your decision making? And secondly, could the risk of decompensation be lesser with a minimally invasive approach because we do know that it causes reduced metabolic response to trauma? If you're operating on patients for HCC and doing a liver resection, more often than not, you try to do it almost certainly in a non-cirrhotic liver, in fibrotic livers, depending on the level of fibrosis. If you got a cirrhotic liver, then you'd look at the synthetic function, preferably you'll operate on a Child's A patient with pressures less than 10. If you're in doubt, what we do adopt is sometimes a non-lesional liver biopsy to help you to characterize what the background liver that you're going to leave behind is like. What I would say is you should have a clear surgical strategy and there should be no evidence of macrovascular invasion or metastases at the time of resection. And if you are going to resect in a cirrhotic liver, the extent of resection does matter. So therefore, if you can use ICG clearance and give you some idea about the functional element of the liver, it is important. The principles are very similar. I do believe this is an important point. Review the pre-op radiology very carefully and map out your anatomy for the resection very clearly. Use a laparoscopic ultrasound when necessary because that helps you to actually, particularly if you're going to do a non-anatomical resection or parenchyma preservation, you've got to have a good ultrasound machine and be able to use it. I do believe that a Pringles maneuver is useful, and I always, as you will see, have a Pringle tape around or a Pringle ready, because once you get into bleeding, then to get a Pringle tape around is much more harder. So always make sure you have a Pringle ready. You may not use it, but keep it ready. I also believe that you should have advanced suturing skills if you're going to take on and operate on these patients who've got tumors within cirrhotic livers. The key determinant, however, is minimize your blood loss, because we do know this has a direct bearing on the level of decompensation that can occur in cirrhotic patients. And if you have an ICG camera system, do use it because it's useful. This is the first case, and this is a patient with a tumor in the right lobe of the liver, and we were planning in a Child's A, and we're planning a laparoscopic right hemihepatectomy. And what I would say is, I use an instrument called the Lotus, and you know that there are lots of energy devices in the market, but this is the one I prefer. As you can see here now, this is the portal pedicle being dissected. The artery has already been put on a sling. I prefer to put the major vessels on a sling before you clip and divide, because it gives you traction, as you can see here, and allows you to apply the clips much more precisely without getting any additional tissue beyond the vessel. And once you've taken the inflow, you get your level of demarcation. The energy device, as I said, I wanted to say a couple of so the chances of you making a hole into the hepatic vein are much lesser with this device. The other maneuver that you can use, as people have demonstrated before, is use it like a CUSA. So here you can see I'm dissecting out V5 by using the ultrasonic bit of the blade. And once you've dissected it, then always remember, before you tackle that vein, clear the liver proximal to the vein, because if you run into bleeding, then you're going to be in trouble if you've not cleared the liver proximal to it. So I do get a good clearance of liver before I put the Leahy around the V5, as you can see here, and then you can apply your Hem-o-lox. And we saw over the last day, elegant videos yesterday by Vivek on how stepwise you can do parenchymal transection. And the principle remains, and as we discussed with Daniel Cherki yesterday, be meticulous. Be very slow. Slow is good for me. This is the bile duct, and again, when you're stapling the bile duct, make sure that none of the other clips that you've got come in the way. So use an instrument to try and retract those clips away before you apply your stapler, otherwise that's going to misfire. So these are little tips for doing the hepatectomy. We now come on to V8, as you can see, and you can see again, I'm using the instrument as a CUSA and trying to dissect out the V8. You can see the middle vein there very clearly, and once you've dissected out, again, you can see I'm going beyond the vessel, clearing the liver parenchyma before I put the Leahy around. So if I run into bleeding, I am in control and I'm not out of control. And again, once you've got the V8 dissected, as again you see, use the Hem-o-lox to apply it. Always half occlude the Hem-o-lox as you go in, because that allows you for better application and it does not catch another tissue. And once you divided V8, then you can proceed with the parenchymal transection. For constraints of time, I've not been able to show you the cable clearance, but as we discussed yesterday, it's extremely important. This is the cavohepatic ligament, and again, we are using a gold finger to go around it. And in this case, we used a mini stapler because there was a vein there. Here you're on the right vein now, and as you come to the end of your parenchymal transection, you can apply a stapler again once you got oncological clearance of the resection margin. You can see the instrument that's helping you to angulate the flexible stapler to occlude the right hepatic vein before you fire the stapler. All I can emphasize is meticulous parenchymal transection is essential to achieving a good oncological outcome and avoid decompensation in the cirrhotics. So that's the first case. When you talk about HCCs, the other thing you can get is recurrent HCCs. And you can see here the Pringle tape being passed around. I use an extracorporeal Pringle. And this is a patient who had a previous segment 2 resection, as you can see, and now has got a recurrent HCC and needs a laparoscopic left lateral. You might think that this is a small resection. It's very easy to do. But believe me, if you run into problems with bleeding, you can end up losing the patients. So, or getting into decompensation. So again, I always believe do this parenchymal transection with inflow. In this case, I used inflow control, and you can see I'm doing the parenchymal transection very slowly and very meticulously. And I do not believe in rushing in this aspect of the procedure. Cirrhotic livers are a challenge if you run into bleeding, and I'll have a small video at the end to show you what problems you can run into. Once you got to the left hepatic vein, again, the principles are the same. You pass a sling around, allows you to get control of the outflow before you can fire your stapler. And again, for the interest of time, I'm going to move to the next video. And this is a patient who had a HCC in the left lateral segment of the liver. And we initially proceeded to doing a non-anatomical resection of this tumor. And we can see here that the tumor that has been mapped out in the left lateral segment, you can use an ultrasound to confirm that you've got adequate margins. Ideally, you know, people would argue you could do an anatomical resection, but a non-anatomical resection is a perfectly feasible thing to do. Make sure you've got adequate margins by using an intraop ultrasound. And again, here, once we've done the oncological resection of a non-anatomical resection, the histology was that of a HCC, and it was a mixed tumor with clear resection margins. However, about 12 months down the line, the patient developed a recurrence in the left lateral segment, and the plan was to proceed to a left lateral liver resection. And again, you can see here, all I wanted to point out to you is there's going to be a lot of adhesions sometimes to the diaphragm. And surprisingly, sometimes you see very little when you're doing a minimally invasive approach. But somehow I've seen in cirrhotics, sometimes you can get a lot more adhesions. So you got to be prepared again prior to your parenchymal transection, get your exposure well. And the only reason I'm showing this video is here I could not get at Pringle's maneuver with a tape. So I had to use a vascular clamp. So this is something that you can keep in your armamentarium. And you can see here that goes across the hilum quite nicely. because I could not get in from the right side, which is where I prefer to go from. And then you proceed to parenchymal transection. So I'm not going to go through the whole procedure here and touch on just this bit, which is using ICG. This was a third time redo liver resection in a cirrhotic. And again, just to demonstrate here, you can use ICG to clearly show you where the tumor is before you proceed to parenchymal transection. The next video that I'm going to show you is the problems you can encounter in a cirrhotic liver if you run into bleeding, and what you do when you run into bleeding. As we heard over the last 24 hours in this wonderful seminar that's been organized by Vivek, keep your cool, don't panic, and handle this. Now, this is something that you will see here. I do not advocate using a hook for doing the left triangular ligament, and you'll see why. This is one of my really good senior fellows who's now a consultant, and he does not feel embarrassed when I show this video. You can see the left vein's now been taken up. He hasn't realized it. And the next bit that's going to happen is that the vein's going to open up. And this is a cirrhotic liver HCC resection. And you can see here what he does. He gets the swab on top of that, does not panic, waits for preparation when you get your needle holders ready. And the next step is you get your stitch in. And when you put your stitch in, you got to make sure that you do what we call in transplant surgery, you do one stitch above and one below, so you close the buttonhole. And you can safely do this. And in this particular case, once we've done this, what you do ideally is reduce the pneumoperitoneum down to 8 and see if there's any more venous bleeding. And we saw that there's still bleeding coming from there. Put a second stitch in to get complete vascular control before proceeding to the resection of the tumor. So again, just a tip about how to handle bleeding in cirrhotic livers. What about the second aspect of the talk, which is when you talk about patients undergoing hepatectomy, is there any evidence that there is a reduced risk of decompensation? And this is a fantastic study. That's a French study, came from Sobran's group. And you can see here that they looked at an ordinal model to predict the risk of symptomatic liver failure in patients with cirrhosis undergoing a hepatectomy. And again, the aim was to build a prognostic model, and they used 26 preoperative and 5 intraoperative variables. And the primary endpoint was post-hepatectomy liver failure. And what was examined was the use of a laparoscopic approach with an intention to treat basis for ITT laparoscopy or per protocol laparoscopy. And that included the exclusion of conversion to an open approach. And what they concluded was that intention to treat laparoscopy was associated with a lower risk of post-hepatectomy liver failure. This is the first study that's shown that in a large cohort. And therefore, the postoperative model that they created yielded significantly better predictions. So the conclusions were that there is clear evidence now that if you use the minimally invasive approach to resect patients, particularly HCCs in cirrhotic livers, there is an associated lower risk of decompensation. So if I were to summarize, Chairman and colleagues who were at the meeting, the decision to treat has to be that of a multidisciplinary team. Assess the synthetic function carefully, because that's going to be an important determinant in terms of outcome. Liver resections in cirrhotics requires a good anatomical assessment with regards to the feasibility of doing a resection. Whenever possible, I always believe keep your inflow tape ready and use a Pringles if necessary. Parenchymal transection, I cannot repeat this more often, should be done meticulously and slowly. And early detection of complications would avoid decompensation. And there's no question that a minimally invasive approach is associated now with a lower risk of post-hepatectomy liver failure. And if you want to do well, as we've seen again from Vivek and his team, always have a very good team. I was lucky in Leeds to have a fantastic team. And now at King's, I've got, again, a very good team to help me develop this program successfully. Thank you very much and stay safe. And I'm happy to take any questions.
Fantastic talk, Krish. Vivek here. As usual, you are hell of a speaker and your videos were amazing and you've given such good tips. It speaks volumes about the quality of work you do. So I think over to chairpersons for asking any questions or further the discussion, please.
So Abhijit decides. So it was a great video, and it's actually a complete thing when you talk about the complication and how to handle the complication. That makes the entire story pretty clear, and that speaks volume about you and your team and how well you're doing. So really appreciate that. I guess if there are any questions from the participants, we'd be happy to take that.
If there are not any questions, I would like to ask Krish one question. And your comment about being slow and meticulous is really what matters. I think
Yeah.
you might be slow initially, but you end up faster if you are
Yeah.
meticulous. So that is
Absolutely.
one thing. I want to ask you two or three things. First is, do you always like to fire staplers on hilum, or you prefer clips? Because many surgeons in Korea, Japan, and including us, have now started doing clipping of, because staplers, they put some holes there and there might be some consequences to that.
No, I think it's a very good point, and I think what I do is, if I can, in that particular video you saw in the cirrhotic, I preferred a stapler. But if I'm doing a right hepatectomy for colorectal liver metastases, for example, and I can dissect the right duct very clearly, then I would use a hemalock without a question, and divide it using a hemalock. I'm pretty easy with that. I think that particular step, you're absolutely right. Staplers are instruments; they can misfire. So you got to be prepared. And that's why I showed how you can get the clips out. We've had situations where I did not realize, having done a portal vein embolization for volume augmentation, I was doing exactly what you said, which is firing a stapler across the bile duct. And I could not realize why the stapler was misfiring until the coils that had gone into the portal vein and then spilled on into the bile duct started to come out of the bile duct. And then I realized that actually it's the coils that are preventing the misfire. So yes, it's a very important point that you make, that if you can dissect the bile duct clearly, you can use a hemalock as opposed to stapling it.
And you mentioned about micro staplers, smaller
Yeah.
staplers.
Yeah.
So in India, we don't have those. Can you elaborate on that?
No, I think it's the you get the shorter ones, which is the 45 millimeter ones, and they are ones which sometimes don't, as Daniel alluded to yesterday, they are the ones that are like the TAs, which don't cut and divide, don't staple and divide rather. They'll only staple one end, and then you can put a hemalock on the other end, and then you can cut it. So they are smaller and easier to get into smaller little nooks, because if you use an echelon flex, it's quite a bulky instrument to get, for example, into the hepatocaval ligament. So yeah, but it's not, as I say, these are changing dynamics every day. New staplers, as you heard yesterday, TA30s now and TA45s are going out of the market. They're going to go bust. So we'll have to think of innovative ways of dealing with it. And I said, as I say, the most important thing is, if you're firing a staple on the right way, and I forgot to say this, I always have my vascular clamp ready.
Yes.
And I have a Johann, which is a flat fenestrated instrument in my left hand. Right. If you do run into problems, then you can apply the vascular clamp, and therefore you got to be prepared to stitch.
Right.
So there is one question for Krish. Can you elaborate your technique of laparoscopic Pringles?
It's very simple. The principles that I use are the same that we use for open surgery. I use a 5 millimeter port through which, so I place two 5 millimeter ports, one in the right subcostal region. And the way I insert that port is it almost goes perpendicular to the hilum. And it goes in from one end. So if you can see, it goes in from this end. You got the hilum perpendicular there. The tape passes underneath the foramen of Winslow, and you pull it out through a 5 millimeter port through the left lower quadrant, and use a NG tube or an IV feeding tube to snug it all the way in. The 5 millimeter port comes out, the snugger goes in. The tube, the NG tube that you use, or the feeding tube, the IV feeding tube, is the same diameter as the 5 millimeter port. So you don't get any port leakage or loss of new peritoneum as a result of it. So I found it quite useful. And it's very easy to do. Snug it, snug off, very easy. People I know use clips with an intracorporeal Pringle, but I find the extracorporeal one much more easier to handle. And it simulates basically what we do in open surgery.
I guess if there are no further questions, we can move to the next speaker.
Thank you very much. Thanks, Vivek. Thanks for the invitation, Vivek, and the team.
Thank you, Krish.
Fantastic meeting. I really enjoyed the meeting.
Thank you very much. Yeah. Thank you very much.
Thank you. Yeah, for the next talk, I would like to invite Professor Hugo Marques. Professor Marques is the professor of surgery, Nova Medical School, Lisbon, Portugal, Head of Liver, Pancreatic and Biliary Unit at Hepatobiliary Pancreatic and Transplant Center, Lisbon, Portugal. He is also the Vice President of the Portuguese Surgical Society and Principal Investigator at CDOC. He is also in chair of the Advisory Membership Committee of the European Surgical Association. Over to you, Professor Marquis.
Thank you very much. First of all, I would like to thank the organization for the privilege of participating in this table and in this session, and particularly to Professor Ashish Singhal also, and to say it is a privilege and a pleasure to be here in a session with many friends. I don't know if you can see my presentation.
We can see. Proceed, please.
Okay. So, having some trouble here, I'm sorry. Okay, so we're going to move to a maximally invasive approach and speaking about liver tumors with IVC invasion. There are many important rules in liver resection. One of them is to adapt the procedure to the disease and not to the surgeon. And therefore, if the surgeon is not able to perform this kind of resections, this does not mean that the patient is not resectable. And in fact, many surgeons, especially ones that have experience in transplantation, are many times able to resect complex patients with invasion of the IVC. The techniques that I think that are more used for those ill-located tumors are in situ total vascular exclusion that can be done with hypothermic perfusion, with veno-venous bypass, or with partial or total IVC clamping. We can do ex situ liver resection and ante situ liver resection. In fact, in situ total vascular exclusion, you clamp the hepatic pedicle and the vena cava above and below the liver. This causes a major hemodynamic intolerance, and about 10 to 20% of patients need veno-venous bypass. And in fact, it is very important when we plan a resection of the IVC and the liver to plan in advance the possibility of having a veno-venous bypass every time this type of IVC resection is scheduled. Nowadays, and I always remember my friend Paul Dark speaking about this and saying that we should use, for this kind of procedures, parts of procedures that we are used to perform, such as in transplantation. And for example, in our team, we gave up veno-venous bypass a long time ago for transplantation, but we have a large experience in ECMO support in the ICU. So we have a team in the ICU that supports our surgical team in the OR. And in fact, what we usually is this provides partial or complete support for oxygenation and respiratory function, allows ventilation with lower tidal volumes, provides better myocardial oxygenation, and can be continued even after surgery if required. Of course, this requires expertise. There is an increasing risk of bleeding during surgery. There is a potential inflammatory response and the risk of vascular complications as in veno-venous bypass. Hypothermic perfusion protects the parenchyma, allows a better vascular control, and it is most treated for difficult vascular reconstructions. And we have seen with the work of Professor Azulay that this is especially useful if you need a total vascular exclusion of the liver for more than 60 minutes. In fact, he has one of the largest case series of the world. And we see that not all of the patients required vascular reconstruction. And still, the mortality is around 20% in his series. So this is in fact a technique that should be used for very, very select patients. Regarding anticoagulation policy, this is an open question. Systemic intraoperative vaporization, when we use vascular grafts, is performed in almost all studies. Long-term anticoagulation is debatable, but we know that the great patents patency, the graft patency seems to be worse when we use Dacron grafts. In our experience in Lisbon, this is 2 years ago, we are around 80 patients, we have around 80 patients now. Most of the patients were operated by liver metastasis or by cholangiocarcinoma. Around 1% of the patients received the synthetic grafts, and we use mostly total vascular exclusion. In 25% of the cases with bypass, ex situ was reserved to only 4 cases. We have 4 patients with late thrombosis, 3 of them with Dacron grafts. You can see here an example of an ex situ procedure. Here, another ex situ procedure for a very large cholangiocarcinoma with reimplantation of the right hepatic vein. Here you can see another example of an in situ perfusion procedure with hypothermic perfusion and veno-venous bypass with ECMO using portacaval shunt. Another image of this, you can see here. And here, for example, a very committed to resection using veno-venous bypass. This is our results. In the first 66 patients, we have 38% 5-year survival. And I presented some illustrative cases. The first one is a 63 years old female with an intrahepatic cholangiocarcinoma that invades the IVC. She submitted to a right hemiapatectomy in 2011. R0 resection, she does adjuvant gemcitabine, and later we can see the 2 years later that she has no recurrence, but then you can see that 5 years after the first surgery, there's recurrence involving the IVC and segment 1. And you can see here that there is no involvement of the hepatic veins. For this case, we planned only total vascular exclusion. This is the first part of the operation, of course, a lot of adhesions. We could encircle the IVC below the liver. Here, separating segment 1. Here, the common trunk of the middle and left hepatic veins is isolated, and also the suprahepatic IVC. So you can see here the tumor located in segment 1. And for this easier case, what was done was a total vascular exclusion using a Pringle maneuver and clamping of the IVC below and then above the liver. So in this case, since the time of clamping is short, with total vascular exclusion, no veno-venous bypass, no cooling, and our preferred method of reconstruction is with a PTFE graft, a reinforced ringed PTFE graft with coated heparinization also, as you can see here. This is the inferior part of the graft. And then the final aspect, and then clamping. Removing the Pringle maneuver, removing the inferior and the superior clamp. So this is, I would say, a simpler case. IVC liver invasion. This is a CT scan 4 years post-rib resection. The patient is still doing fine. And this is a more complex case where you can see a woman with 67 years old that in August 2016 has an intrahepatic cholangio involving the right lobe, the IVC, and the hepatic veins confluence. This patient was first submitted to a portal vein embolization. And you can see here in the CT scan that in fact, the 3 hepatic veins were involved. And for this patient, we planned a different approach. For this patient, we decided an in situ surgery with hypothermic perfusion and veno-venous bypass with ECMO. So you can see the regular incision. Here at this point, we have the elements of the right pedicle that are already separated. This patient has a replaced left hepatic artery. We decided to start ECMO in the beginning of the procedure because this allows us to have less blood in the operative field, and in fact it's easier to transect the liver at this point. No total vascular exclusion at this point, just regular exclusion of the right ham liver, as you would do, for example, in a living donor. Here we are using harmonic, the ultracision, the bile duct, the right bile duct, then the portal vein. She has a right anterior and right posterior separated pedicles. Right posterior pedicle is then taken. And we use this pedicle at the right parts to use it to do the perfusion. That is not done yet. Of course, we are just going to do it when we clamp, when we start the vascular exclusion. And at this point, we test clamping of the IVC. The patient tolerates it under ECMO. And so we start total vascular exclusion and we start the perfusion of the liver with perfusion solution. So we clamp the hilum, we clamp the inferior IVC, the superior IVC, the left hepatic artery accessory is also clamped, and we finish the transection under vascular exclusion. We reconstruct the left hepatic vein using also parts of the umbilical vein to enlarge the orifice. So at this point, we place the Dakin grafts in the superior part of the IVC. We confectionate an opening for the left hepatic vein, the drainage of the left liver. Inferior parts. And finally, the drainage of the liver and the hepatic vein using part of the umbilical vein is finished here. So we can finish the vascular reconstruction. We can then unclamp, remove, of course, the perfusion. And then remove the Pringle, remove the accessory vein, and remove the clamps of the IVC inferiorly and superiorly. And you can see finally the final aspects of the liver after a perfusion. That you can see here. Finally, another example that I would like to show you is this 67-year-old female with an intrahepatic cholangia that is involving the IVC and the right and the middle hepatic veins. And in this case, the invasion of the right hepatic vein was very focal, and we decided to do a central hepatectomy with reimplantation of the right hepatic vein and maintaining the left hepatic vein and under ECMO and cooling of the liver. So you can see this is the first part of the section. At this point, we didn't start this is the right part of the resection. So here, the right hepatic vein is going to be exposed. Here we are confectioning portable shunts and preparing for the start of the ECMO. So portable shunt is done. ECMO is started. This is the right hepatic vein that is being exposed. Under cooling of the liver. Sorry, implantation.
Professor Hugo, can we just move because we are short of time? So can we just wrap up?
Yes. So this is, just to show you, this is, we are using a cadaveric graft this time. And this is only the final parts. Of the reconstruction, the right hepatic vein reconstruction, and the IVC with the cadaveric graft. So I would say to conclude that veno-venous bypass may not be systematically needed, but should always be prepared and should be used if more than 60 minutes of ischemia is anticipated, especially with hypothermic perfusion. Frequently overpass 60 minutes, and in our experience, PTFE is preferable to DECRA, and long-term anticoagulation is debatable, although we use it. So this approach does not benefit all patients. There is not a clear-cut choice between in situ, ex situ, and ante situ, but there is no doubt that some patients take clear benefit from this aggressive approach as long as a reasonable morbidity and mortality are maintained. Thank you very much.
Yeah, thank you, Professor Hugo. I think we have a question from Ruslan. What you may say about the cold perfusion in patients with compromised liver function after chemotherapy or jaundice? And how do you assess the risk preoperatively?
Thank you very much. It's a very important question. We always use indocyanine green in those patients. We only do a major vascular resection if you have less than 15% of retention at 15 minutes. What we do also is similar to, because of this reason also, we have a cutoff of 40% of remaining volume for those patients also.
Excellent talk, Hugo. I think we are running short of time, and I think there's no questions. Dr. Abhideep, do you have anything?
Yeah, no, I guess we're running short of time, but just a quick question. Is there a cutoff of bilirubin levels which you look at when you are considering someone for these kind of resections?
Yes, we wait until the bilirubin is below 2. All right.
All right. Thank you. We move to the next last talk for this session, and the master is already here, Eduardo Fernandez. He's going to talk on complex hepatectomy with vascular reconstruction. He's a professor of surgery at Rio de Janeiro Federal University, and he's the chief of abdominal surgical oncology and transplantation in Brazil. Eduardo, the floor is all
Yes.
yours.
Hello, everybody. Can you guys hear me?
Yes, nice and
Okay,
loud.
so thank you so much. Sorry for this. I am in the airport right now in the middle of a connection, but I was so proud to be part of this group. And I want to thank my friend Orlando Torres that he's supposed to give my talk in case I fail, but I could make it. So thank you so much, Ashishi. You're a very special friend. And I just want to remind you guys that about a year ago, we were in India in this meeting, right? So unfortunately, now we cannot be all together there. So my topic today is complex hepatectomy with vascular reconstruction. And after Ugo is a very difficult task because, as you know, Ugo is a master on these operations. So I still a student compared to Ugo. So I'm gonna show you today some of our cases. We have a pretty good experience with vascular reconstructions in major hepatectomies. This is a very old case that we did right hepatectomy with IBC resection with thoracotomy. You can see the lung on the back. So this patient survived for 6 years after these major operations. You can see the picture here. I was looking a little bit younger at this picture, so that was pretty long ago. I'm going to show you the video. This is a very interesting case. I think was one of the first cases in the world that the patient with intrahepatic cholangiocarcinoma who underwent neoadjuvant treatment and was referred to us after chemo as a unresectable case. And the tumor was pretty big and the remnant liver was only 31%. So we can see on the image right here, the tumor was invading the three veins, and we can see a stricture on the left hepatic vein right here. So, and we were dealing with a small remnant, left remnant. So we decided to do an AILBS procedure. As we can see here, this is a total AILBS procedure. So on the first part of the procedure, we did the AILBS, and also we replaced the diaphragm with a PTFE graft. And we didn't mobilize the liver completely because the tumor was invading the distal part of the IVC and also the distal part of the left hepatic vein. So with the CUSA, we can get a healthy part of the left hepatic vein, as we can see here. So that's why I am one of the defenders that AILBS should be total AILBS. We have to avoid partial AILBS because, you know, we make the second operation much easier. So we encircle the left hepatic vein here with this vessel loop, and we already prepared the diaphragm, as we can see that little part of the resection. And also we did the hilum. We skeletonized the left and the right vessels. So that's going to be very useful for the next operation. So that was one of our tips for the AILBS. We left the catheter on the IMV to measure the portal pressure. This is the second operation. We are preparing for the antecytal perfusion. We can see this catheter on the portal vein. So this is 2 weeks later. The liver grew about 100% in 2 weeks. So that was the left hepatic vein that we left intact. So that's the clamping of the pedicle to start the perfusion. As Ugo said, antecito is it's a very good technique because we guarantee a good perfusion for the remnant. There's no bleeding at all. So the funny of this case is we obviously need to do a total vascular exclusion and start the perfusion. We cut the left hepatic vein and make sure that the veins are clear of tumor cells. Send them to frozen section, So now we start the perfusion. We can see the HTK flowing out. That is the bottom cava. We can see the tumor touching the IVC there. So the idea will be to replace the cava, as Hugo said, not beautiful as Hugo operating, but this is what we are trying to do. So we're gonna disconnect the liver totally from the IVC. So then we're gonna cut the bottom cava and make sure we have no tumor on the vein. We froze the margins, everything is clear. So now we're gonna transform it in a regular liver transplant. So we're gonna do, this is a dacron. I prefer the dacron because it's softer and it's easier to deal with. So we're gonna do like a liver transplant, a conventional liver transplant. That is our favorite outflow reconstruction. So we transform it in an end-to-end, doing the posterior wall, the cava. And remember, we are flushing the liver with the HTK with 2-3 liters, or as much as needed. But 2 liters is enough to keep the liver a little bit low temperature. So after finishing the upper cava, it's very easy to do it. So that's the bottom cava. So now, after that, we need to reimplant the liver. So that's the funny of this case. So after the AILBS, so 2 weeks of preparing the liver to grow, we did the second stage, and then applying the vena cava resection and reconstruction. So now we are reimplanting the left liver remnant on the graft. So that's why, dacron is much easier to deal with. As we can see here, it's softer and it's easier to reimplant. Dacron is softer, and PTFE is a little bit tougher, but also very good option. So it's important to guarantee a good outflow. So after that, we're gonna release the clamp and reperfuse the liver. It looks like 30 minutes to all that stuff. So the liver looks good and the operation is done. So AILBS is a safe procedure, even if we need to do a complex reconstruction later. So as we can see here. So do I have 3 more minutes, or we're done with the time, Ashish?
I think if we can quickly wrap up.
We need to finish?
Yeah, if you can just finish up fast.
Okay, we had another video, but we can maybe show it in another meeting. That was a very difficult case with intracardiac tumor. So in summary, what I want to mention is hepatectomy with vascular reconstruction is a very complex operation. Surgeons need to have experience with liver surgery and most of all with liver transplant. And the preoperative plan is very important to make and guarantee a safe operation. Obviously, it has to be performed in a specialized center and avoid liver dysfunction, because as we know, major resections, including vascular clamping, we have more chances for liver dysfunction. And as Hugo said, this is very important. If you are unsecure, make the tumor as ex vivo because it's going to be like a living donor later, so very safe and no bleeding. So that's what I want to say. Thank you so much for the chance to be here with you guys.
Thank you so much, Eduardo, for wonderful videos, I must say. Do we have any questions from the audience? Dr. Vidip, are you there? Yeah, Dr. Vidip, you need to unmute. Dr. Vidip, can you unmute yourself? Yeah, just a minute.
Yeah, so I was unable to unmute. So great video and really impressive thing. And the last 2 days, I would say you guys have done great thing. I mean, even yesterday and today, it was really good. It was actually a good surgical meeting, I would say.
Thank you, Dr. Vidip. Yeah.
Great show, Eduardo.
Can we have any questions, or we should move on to our next session?
Can I just ask one question, please?
Yeah, please go ahead.
Just to say, it was a pleasure to see my friend Eduardo, which is an actual real master in this type of surgery, to show this so interesting video. And I know he has a lot of experience in this. My question is about the Dacron grafts that you use. I agree they are easier to use. And even the orifice that you create on them for the implantation of the veins is different because you don't have the rings getting in the way. So there are a lot of advantages. My question is, do you have late cases of thrombosis with those grafts, like 2-3 years after?
Hugo, this is a very good question. I was expecting to have that question from you, but you know, in my reality in Brazil, we are not rich as the Portuguese, so we use what we have in the hospital. So if we have PTFE, we use PTFE. If we have Dacron, we use Dacron. And nowadays we are using a lot of peritoneal patch, so you can create a new cava or a new portal vein with the peritoneum. So this is a very good idea, by the way. And if we have cadaveric veins, we also use the cadaveric veins. But we don't have late thrombosis. This is very interesting. I keep the patient with aspirin forever, 100 milligrams per day, forever. And so we don't have any difference in the thrombotic rates among all these kind of grafts.
Do you use warfarin as well for the first few months or days?
No, I don't use warfarin because warfarin is a little bit more difficult to handle, and aspirin is very easy. The patient gets 1 pill per day in the morning, and that's it. So there's not too much difference.
Definitely. Thank you. So
thank you so much.
Thank you. Thank you. Thank you, chairpersons and speakers for the wonderful session. I think now we can move on to the next session on
Eduardo,
transplant.
a question for you. Do you think the aspirin works equally in the vascular venous reconstruction as the Vishal has been pointed out?
I think he has left. He has logged out.
All right. Okay.
Hello. So for the next session, I would like to request Dr. Arif to invite the chairpersons.
Moving on to the next video session on transplant oncology, I would like to invite the chairpersons, Dr. Varyar Ketner, who is Assistant Professor of Surgery, Division of Transplant, Department of Surgery, University of Minnesota. Dr. Prakash Jain, who is a Senior Consultant, General GI and Lab Surgery, Kingsley Hospital, Nagpur, India. Dr. Ashish Mishra, with a liver transplant and FPP surgeon at Apollo Hospitals, Lucknow. Dr. Alfred Cow, Associate Professor, Division of FPP Surgery, Department of Surgery, Senior Consultant, Liver Transplant Program, National University Center for Organ Transplantation, and Assistant Dean, Yong Lu Lin School of Medicine, Singapore. Dr. Bishir Dabal, who is a senior gastroenterologist and hepatologist at Shami Medical Center, Damascus, Syria.
Request chairpersons to please introduce the first speaker.
Right. Thank you very much for the kind introduction for all of us. I shall start the session for video 2 now. It's a great pleasure to introduce Dr. Mariano Jimenez, who doesn't need much introduction because I think most of us know him very well. He's the professor of surgery at the University of Buenos Aires, Argentina, also the professor of percutaneous surgery at the University of Strasbourg, France. He also has a significant contribution at the Strasbourg ERCAT as the director of percutaneous surgery, and currently he's also the president of the DICIM Foundation for Argentina, as well as the chairperson for International Relation Committee for AHPBA. He'll be sharing with us the minimally invasive treatment options for liver tumors. Professor Jimenez, please.
Thank you. Thank you very much for your kind invitation and for your kind introduction. Well, I'm talk about the percutaneous and laparoscopic treatment, and really is about the ablation, and show several short videos with this possibilities of treatment of a liver tumor. Of course, we have the surgeons, we have more and more high quality images in our practice, and we have the possibility to move our activity to the operating room, to the CT room for treat percutaneous treatment. And we change our classic surgeon operating room in this hybrid operating room. We have the possibility to make into our surgical rooms more technologies, CT and MRI and CBCT in our practice. We change our classic laparoscopic or open or robotic surgery with more possibilities of treatment. When we analyze the success rate and the morbidity and mortality of the ablation therapy, it's possible to increase the number of cases in the last years, and with a very low mortality, less than 1%, and the complication less than 3%. For that reason, it's very interesting to make this these new therapies. Of course, the days in hospital after ablation is in 0 to 1 day, more than 85% of the patients. And when we analyze the current international guidelines in, for example, ACC, it's possible to view the ablation is a competition with resection, and when we treat this patient with the idea to cure the disease. When we analyze the guidelines in the extrahepatic primary cancer and metastasis in the liver, is the same way. If, for example, this new paper of the Japanese Society of HPV Surgery is an interesting paper by Yamamoto, is one when we talk about the local ablation. It's not more highly recommended, but not less than resection. And this is one of the possibilities of the ablation in the world, has more and more indicated in our patients. However, with all this fantastic, but when we study the systematic review and meta-analysis of which is better, the resection or ablation in the liver tumor, is the resection is better. It's not two more, but it's better of the ablation. Which is the reason of this in this moment? Because the ablation margin in our ablation is not useful, is insufficient. We have a problem with this. And this is a very important thing, because is another problem of the ablation, The tumor location is surface or in the middle of the liver, the tumor size more than 3 centimeters, and proximity to the largest vessels is important, but it's not essential because it's possible to treat a patient with several tips and tricks. But the margin size is essential. For this Sargent march and the biology of the tumor is we need 5 millimeter or better 10 millimeter of ring around the tumor, and it's necessary to ablate this ring above the tumor, and this is essential in the result, in our results. When we have less than 5 millimeters, the possibility of progression is near to 100%, and when we have more or 10 millimeters of diameter around the tumor, we have the progression is very similar to the surgery, 2% of cases. For that reason, the key of the new treatment, and it's necessarily performed by HPP surgeons, is the precision ablation with 5 different things. First is the planning. And the planning is a choice of approach, percutaneous or laparoscopic. At this moment, we use more and more in the world, more and more percutaneous and less laparoscopic, because has a better results. It's a very interesting new paper of the MD Anderson about this. Second, with planning and choice of ablation system, it's not possible to treat all the tumor and all the patients with the same ablation system. We use in 70% of cases microwave, and 20% radio frequency, 25%, and 5 to 10% IRE, reverse electroporation in the liver. And this is a homemade table to use these different, really, we don't have experience with cryo in the liver, because in the Occidental countries, not useful in the liver, is more in Japan and South Korea. But in the liver, we use in the small tumor, less than 2 centimeters, microwave or radio frequency. Really, at this moment, we prefer microwave. We changed in the last years. In the tumor more than 2 centimeters, we use or microwave or radiofrequency with multiple needles. In tumor near the peripheral, not important vascular structure, we prefer microwave, and we use IRE, irreversible electroporation, when tumor near the biliary or central vascular structures. In the preoperatory, we use the 3D CT, similar to the when we use this planning for our resection. We use the same idea with when we perform ablation. In case of we treat patient with the previous trisectionectomy, we use the functional studies and the anatomical studies to observe the possibility of hepatic liver failure in the future liver remnant without ablation. Is the same idea. And at the moment of our procedures, we perform, and this is one of our fellows, perform the new planning at the moment of the ablation. The second tips is the making the invisible visible, because we have more and more the detection of the diagnosis of the tumor with MRI, but we use CT and ultrasound. For that reason, we use a fusion of images to localize the target and introduce the needle in the correct place. And we use more and more technology. And the technology is different things. One is the use of a navigation system. Here is a navigation system in one ACC patient. When we use optical navigation system, and it's possible to localize the needle in the center of the tumor without problem. And in case we use laparoscopic procedures, really it's very useful to use electromagnetic guidance system, because it's for laparoscopic to introduce a needle and localize the tumor, etc., and the precision is complicated. For that reason, this electromagnetic guidance system is very useful. And we have the possibility to use all in our patients. Is the augmented reality, navigation system, and the idea is the precision ablation. And here in this case with Professor Patrick Pesson and I, we perform the percutaneous ablation therapy in one patient with colorectal liver mets when we use the combination of virtual and mixed reality and navigation system, electromagnetic navigation system. And the end of the day, the idea is the experience to localize the tumor, to burn the tumor is with aggressive, is similar to the surgery resection. And control of the patient is essential in 45 days with MRI, and follow the patient with diffusion and ADC map is essential. The surgeons need to incorporate some images technology in our practice. When we treat patients with only one hepatic vein, we have the possibility to use several needles, and or using the portal vein, we have the possibility to use the IRE. And in cases the tumor is more than 2 centimeters, 3 or more, we have the possibility to use 2 or more than 2 needles to destroy the tumor, more than 4 centimeters, 6 centimeters. And in the last year, we have the possibility to perform segmentectomy by ablation in this patient. For example, in this patient with the previous one, trisectionectomy, we destroy several tumors in the segment 4, and we perform the segment ablation of the segment 4. And this is a control of with diffusion in ADC map. And at the end of the day, this is not new. It's in the Nature journal. The team of Reto Valle show the experience with the multiple needle ablation of the tumor with more than 8 centimeters with the local tumor control of more than 90%. This is not totally new. And for us, it is too much for us. I prefer the surgery, of course, me too. But in this case, this is a very interesting thing because it's the future of our practice. But at the end of the day, is the experience is important, yes, but it's not essential because the technology has a better result. In our few month paper of our team, we show the use and navigation system has a better result in beginners than the classic maneuver in the expert. For that reason, the technology is a very interesting thing. Finally, is the immediate control of results is very useful to checking the results during our procedures, and this is essential. In summary, but finish my presentation, is the precision ablation in 2021 is unused. For example, it's not the same of the KRAS mutated or not, etc. We need it. Is our focus in the target, in the tumor, in the patient, more in our technology, the technology of the surgeons. In this paper, on the end of 2018, in the pathology, Reto Valle show that in near to 100 patients before the liver transplant for HCC, Reto Valle performed the ablation. And the ablation has at the moment with the explant liver and study has more than 97% of the lesion without tumor. For that reason, when we use the precision ablation and with the user technology in our ablation, we have results very similar, or is possible better than surgery. And at the end of the day, we need to incorporate this practice for our HPV practice or we need to talk with our interventional radiologist with the idea to change the classic safe ablation to the surgical concept of complete ablation. It's not lost the security of our patient, of course, but the idea is it's the same aggression of the classic HPV surgeons in ablation, and to make the idea to cure the patients. And finally, is the summary, is my opinion, is the team of people treating liver cancer. We need to work together and cross-training of the HPV surgeon and interventional oncologist. Of course, in the future, with the improvement of technology, with more robotic and automation, will be not interesting, because it's possible the robot will be the surgeons or the interventional oncologists on the future. But in the middle time, now and in the next 5 or 10 years, we need more and more work together and destroy the barriers between specialties, and we need to work together with these patients. It's not for all patients is ablation, but not for all patients is a liver transplant or of the resection. Thank you very much for your kind attention.
Thank you, Dr. Jimenez, for the very nice and structured talk on the approach of using ablation and other means to treat liver tumors. Perhaps I can start the discussion by asking a few questions, because I personally also do quite a lot of ablation for liver tumors. You mentioned it quite clearly that there's a shift in your preference to use radiofrequency to microwave ablation, and perhaps I would like to hear from your own experience, why is that this major shift? Because the mainstream literature still supports that the long-term outcome for radiofrequency ablation is superior. But I have a personal view on that, because when I reviewed the literature, it seems that because the technology of the old version of microwave ablation is not as good as radiofrequency ablation, but the new ones are really very good. What are your thoughts about that?
Well, it's very interesting. Of course, we have a more experience because we have more years when the use of radiofrequency than the microwave, for example. My first microwave ablation was in 1999. For that reason, it's a long experience. However, at this moment, we discuss patient by patient, and we have the size of the tumor and the position of the tumor. More than the position of the tumor, a localization of the tumor more than size, really. Because in case the size is bigger, we have the possibility to use several needles. And really, when we have a tumor is 2 centimeters or less, in the past, the idea said, well, this is a fantastic indication for radiofrequency. And it's not true. At this moment, this small tumor is better with microwave, because with only one needle, we have the possibility to destroy this 1.5 centimeters tumor and 1 centimeter around this. For that reason, we use more and more microwave, but not for all patients. And the end of the day is the planning is the most important thing. It's incredible, because the surgeons planning very well the 1 weekend and not planning this ablation. It's a totally crazy thing, in my opinion.
Thank you very much. Perhaps I can also invite the rest of the chairpersons or even the speakers to see if you have any other comments or questions to ask Dr. Jimenez.
One comment, Mariano. This is Dr. Vivek here. Welcome to the conference. Mariano, very nice talk. It was looking like something coming futuristic science fiction. In India, we don't have hybrid OTs, hybrid operation theaters, including robotics, laparoscopy, your CT scan, MRI, and all those. But I think you're right in saying that precision ablation should be the future of ablating these kind of tumors, and that if we precisely ablate. I always used to ask myself a question as a surgeon, that if surgical resection is having better result than ablation, then why? if we can ablate complete tumor, why should surgical resection have a better outcome? So that I used to ask, but you have provided the answers to that, that precision ablation is actually the answer, and that hybrid labs and hybrid operation theaters are the way forward to it. Looking forward to visit your center and look forward to see all the technology you use. It was really nice.
Oh, thank you. Thank you.
All
Well,
right.
I'm through.
Right. Thank you very much. If not, then I think we'll move to the next speaker.
I would like to thank the organizers for giving me a chance to chair the session. I would like now to invite to the podium my friend as well as a colleague, Dr. Ruslan Alikhanov. He is the head of liver and pancreatic surgery and transplantation department at Moscow Clinical Scientific Center, Russia. And he will be discussing laparoscopic liver resection for liver tumors, evolution, and technical challenges. Dr. Alikhanov, please.
Thank you, Varya. Thank you, Vivek. Thank you, Ashish, once again for inviting for such fantastic conference. I'll talk about laparoscopic liver resection for liver tumors, evolution and technical challenges. In the past, when I was just a resident of first 2 years, one of my old-fashioned mentor said to me that laparoscopic surgery, especially in liver surgery, it's just a fashion and never be established. And it's like underwear that it changed during the time. But it was logical that to use laparoscopy for liver surgery, especially because sometimes we did a huge incision just for remove the small tumor, and the incision sometimes is more traumatic than liver resection. So it was approved by first data that the laparoscopic approach in liver resection has all the benefits of the laparoscopy, like you see in the table. It's less abdominal pain, decreased analgetic. Because of time, I will not say this everything, but you may know this. But still, till now, there are some problems that were met during laparoscopy of liver. It's an inadequate exposure and traction because of huge, sometimes liver. It may be sometimes time-consuming. The very good and very special point, it's bleeding, especially from hepatic veins, and it's difficulty to control. And there is some awareness concerning oncological outcome for liver resection doing laparoscopically. So in 2009 was published the statement of Louisville statement, and it was concerned that considered some laparoscopic segments of the liver that have anterior segments and 2, 3 that may be managed and resected laparoscopically successfully, and it was established that it's very feasible. After experience increased in many centers in 2014, led by Professor Wakabayashi, was second international consensus conference on laparoscopic liver resection, where a very interesting novel difficulty scoring system was also introduced. And this scale of difficulty indicated that there are some different levels of difficulty of laparoscopic liver resection, low, intermediate, and high, and it may be helpful and useful for to do these operations, and especially for learning curve for introducing and doing these laparoscopic liver resections. In 2017, leading by Mohammed Abu Hilal, there was established Southampton Consensus Guidelines for Laparoscopic Liver Surgery. It was first European consensus meeting. Many points there were established, but I want to say about one recommendation, that the modular liver resection and parenchymal resection of difficult segments, including central, are feasible, but should be performed by the experienced surgeon in selected patients and in experienced high volume centers. This is very important and for good and satisfactory outcome. Concerning the I missed this. Concerning the laparoscopic versus open surgery for colorectal liver metastasis, one single center, huge single center data presented by Luca Aldegete and his team showed that there is no difference in a short-term outcome, and there is no difference in long-term outcomes. During these decades, there are some retrospective data comparing laparoscopic and open liver procedures, and we clearly show that there is no difference in laparoscopic liver resection versus open liver resection in terms of long-term outcome. And the huge meta-analysis recently published in International Journal of Surgery also showed that there is no oncological significant difference between negative surgical margins, tumor recurrence, and 3 and 5 disease-free survival. There are only 2 randomized controlled trials concerning the laparoscopic versus open liver resections in patients with colorectal liver mets. One from Oslo, leading by Professor Björn Edvin, who these studies still pending, but they also showed that 3-year survival is the same, and other lab of Hoover, also Spain randomized controlled trial also showed that there is no difference in overall survival. What about the laparoscopic liver resection in hepatocellular carcinoma? Recent status, there are no randomized controlled trials, but retrospective data showed that also there is, concerning in long-term survival and also short-term survival, the results are very comparable, and one of the benefits, proposing benefits for hepatocellular carcinoma in patients using laparoscopic liver resection, it may reduce trauma of abdominal wall, and it leads to less transected collaterals, and that may cause less ascites, decrease infection, and we see in this data that there's a very comparable oncological outcome. There is very few studies concerning the using and comparative studies laparoscopic liver resection for intrahepatic cholangiocarcinoma, but preliminary results also showed that the resectability and short-term and long-term outcome not so are very comparable. And concerning the posterior superior difficult segments for liver resection, we see that the comparative results are the length of postoperative hospital stay and recurrence-free survival is similar for underwent laparoscopic liver resection versus open liver resection. We also published this comparative study recently in surgical endoscopy. We received the same short-term and long-term outcome. So during last 5 years, we had near close to 1,000 liver resections, and half of them, near 50%, were done by laparoscopic liver resections by 2 surgeons. And there are some lessons learned, technical challenges that it is important to not, especially for laparoscopic, it's to understand is the tumor close or no to vascular structures? There is no, or yes, fibrosis or cirrhosis. We always use intraoperative ultrasound for staging, for marking vascular structures and transection line. We're always ready for use Pringle maneuver and place a ghost to the close to operating field. It should be always organized team, very familiar with laparoscopic technique and also with liver surgery, and all instrument should be available. And for learning curve, it's important to start with a minor resection and then to do mater resection, then posterior segments, and then maybe the resection with biliodigestive combined with biliodigestive anastomosis. This is common positions for trocars that we usually use. But most of the time it depends on constitution of the patient. If for posterior segments, not always, but sometimes we use the modified left lateral position, like a swimming. And for portal triad control, we use additional port, and it's possible to use additional port. It's very useful and easy because even non-experienced resident can place the Pringle, make a Pringle during operation on the time. There are many equipment, and I will not stop on that. It depends on preference of surgeons. Most of the time we use ultrasonic dissector and bipolar and harmonic shears. And I want to show on my old videos, this is the patient with huge colorectal metastasis segment 4. For dissection of hepatoduodenal ligament, we usually use harmonic scissors, but not contact with artery by active branch of the scissors. This is old video. For clamping of artery, we use metallic stem, but now we most of the time use hammerlock. We were previously, we really liked to do a tie. It narrowed the vein, portal vein, but now we also used all the time hammerlock on this the step. After we see the demarcation line, we started to mobilize the lever. It's important to clear the part with the caval hilum to see clearly where is the middle hepatic vein and left hepatic vein. It's very easy to do laparoscopically, especially if you place the camera close to here. Now for transection of the liver, we use widely, in most of the cases, we use the ultrasonic dissector. But in the past, we used also harmonic scissors. Putting the energy, you may use it like a dissector, especially with favorable parenchyma. And if it's no fibrosis, it's quite clear. And combination, in the past, we also used ligature. And we were very brave in the past, but now we always use here the clips hammerlock. Here we see middle hepatic vein, and there's the branch from the left lobe. But in the past, we used the ligature even for transecting the hepatic veins less than 5 millimeters, and now we do not do this. We had not problems with that actually, but now we're not so brave. In the we transect during the left hepatectomy the bile duct in the actually after transection the parenchyma, starting transection parenchyma, and for transecting of the left hepatic vein, we use different staplers. It's a site after. So one of the points because we do many now liver resections for bile duct carcinoma, for intrahepatic cholangiocarcinoma, and gallbladder carcinoma. The point was a questionable point about lymphadenectomy, but I may say that we widely use, and it's very possible to use and to do lymphadenectomy during liver resection. You see here they clear all the vessels, and here you see the additional lymph node that we then removed, and here you see that it's possible always. It may be some time consuming, but it's possible to do the same like in open procedure. Also, this is left hepatectomy with bile duct resection. The more you skilled, the more possibilities, and here you see the hepatic adenostomy anastomosis. And if the diameter of bile duct is fit for using laparoscopy, you may do this laparoscopically completely like here, or you may do laparoscopic procedure and small incision for reconstruction using optic. So sometimes even for wedge resection, you may have a problem during laparoscopy, and you see it here, the damage of the branch of the hepatic vein in patients, especially with steatosis like here. It's important not to open on that moment because you may receive and lost the patient. It's possible to do not panic, just clamp first, then maybe to put we always have some gauze here to clamp and wait some time. And after that, it's possible that bleeding is not so big, and that you will see the tears in the vein, and then to under direct vision to do clip this and to stop the bleeding. So it's important now we have this is also evolution, many equipment, many possibilities to use different hemostatic, not only during open but also laparoscopic procedure. And because of laparoscopy is very technology dependent procedure, I think that the laparoscopic approach for liver resection is evolutionary approved, it's not efficient, and the technical challenges and standards should be taken into account for satisfactory short and long-term outcome. Thank you.
Thank you very much, Professor Lihanov. I think while everyone else is collecting their questions, I have a first one for you. For surgeons who are just starting to get into the laparoscopic world, do you recommend an intermediate step of performing laparoscopic hand assist procedures, or there is really no role for this in a liver resection surgery?
I think important factors that for training it should be step by step, and the surgeon who want to perform liver resection, laparoscopic liver resection, should be experienced first in HPB surgery, of course, and certainly in laparoscopic surgery. I may say that most of our young guys who are involving in a training, they do not go through the step of hybrid procedures or laparoscopic assisted procedures, but I think in procedures like very advanced procedures, like for example for cholangiocarcinoma, or when you should to do very precise hepatic adenostomy anastomose, you should go through first laparoscopic assisted step or do hybrid procedure. So I'll ask you a question.
Yeah, thank you for the excellent talk. I just wanted to ask if you do any functional study before a major liver resection, for example, in patients with early cirrhosis or fibrosis, Do you do any kind of functional study? I think the previous speaker touched upon it, like doing the membrofinine scan. Do you do any functional study or go by the regular investigations?
Yes, for patients with, when we plan the major liver resection or a patient with liver cirrhosis or compromised previously by jaundice, we do routinely hepatobiliary scintigraphy. This is priority in our clinic. We have not yet registered ICG in our country. We had it for some preliminary reasons here, but it's only will be introduced, established now. But we do routinely for when we see the risk of post-hepatobiliary liver failure, we do hepatobiliary scintigraphy.
Thank you.
In our clinic.
Thank you very much, Ruslan. It was wonderful talk and great experience. 1,000 resections, 500 laparoscopic. Amazing. We enjoyed your talk. Now, in view of time, shortage of time, I would like to proceed with the next talk. I'd like to invite Professor Ajay Makir, who doesn't need any introduction, for his talk on liver resection for giant hemangiomas. Professor Ajay is Professor and Chief of Surgical Oncology, Maurice Galland Distinguished Professor of Surgery, UCSF. Welcome, Dr. Ajay. Over to you.
Great, thank you so much. Well, I'm just thanking everyone. I had sent in the recorded talk, if that is loaded as well. And I did want to thank all the members of the AILBS organizing committee for the invitation, particularly Ashish and Vivek for the invitation. Really is special to be here. As I think I'll mention, most of my extended family is actually in New Delhi, and so I just wish I could be there in person. But hopefully when the world comes back to normal, that'll be an opportunity.
Soon, maybe next AILBS conference, you'll be here.
That'd be wonderful. So, you know, this topic of giant hemangioma, there is no randomized controlled trials. There's really no description of this technique I'm going to talk about today. So it's really just a technique video, not a lot of data to discuss. The use of preoperative embolization does have some small case series, certainly no randomized data. The best data on embolization for treatment of giant hemangioma is really a 55-patient case series by Liu et al. That was published in Medicine in 2017. And really what that study showed was that embolization for giant hemangiomas has very poor long-term control. Only 12% of all the patients.
Start by thanking the organizers of the AILBS for the invitation to speak at this year's conference. It really is an honor to be here today. I just wish that this had been in person, given that much of my extended family is actually in New Delhi, but perhaps sometime soon in the future. I'm speaking to you today from San Francisco in California, and on the topic of giant hepatic hemangiomas. Now, we all realize that the management of symptomatic giant hemangiomas, which traditionally have been defined as those greater than 10 centimeters, actually varies considerably both in the literature and in practice. And though multiple interventional approaches have been described, and these include surveillance of these lesions, some perform embolization, enucleation, or resection based on tumor size or location, relationship to the vessels, and the quality or quantity of the functional liver remnant. Now, resection, however, is often only reserved as a last resort for highly symptomatic individuals due to the risk of major hemorrhage. Preoperative arterial embolization has been discussed and considered, but usually when this is performed, there's a risk of the patient experiencing severe pain after the embolization, fever, transaminitis, acidosis, often recanalization of the vessels with recurrence or growth of the hemangioma thereafter, or collateralization. And this has all really limited the utility of this approach. Furthermore, many times these patients will require inpatient observation, and we really don't know the optimal timing for the time after the procedure and when to perform the resection if it's going to be performed. And so I wanted to present an example of a technique that we have optimized that helps deal with many of these challenges in a very satisfactory fashion and is a very efficient use of embolization and resection at the same setting to both improve the safety of the resection as well as decrease the overall length of stay. So we'll show that example here. 57-year-old woman presents with daily abdominal discomfort, especially when lying down, when she notices an electric shock migrating to her lower abdomen and legs. When she is anxious, she feels a pulsation in her upper abdomen, and this is occasionally associated with nausea and lightheadedness. Her laboratory investigations are within normal limits, including a normal platelet count. Cross-sectional imaging reveals a very large hemangioma. You can see the inflow is behind this very large tumor and inaccessible from an anterior approach. The lesion replaces the entire left hepatic lobe and abuts the middle hepatic vein throughout its course, particularly at the origin of the middle hepatic vein. Sagittal section shows the full extent of the tumor and again highlights that the porta hepatis and the inflow to this hemangioma is not accessible due to the large size of the tumor. MRI is also performed to help confirm the diagnosis, which again confirms a giant hemangioma greater than 20 centimeters replacing the left hepatic lobe. Resection for these lesions has focused on hemangiomas less than 10 centimeters with techniques in the literature based on the size, location, and relationship to other structures, as well as a functional liver volume. Major complications in resection of these lesions is life-threatening bleeding regardless of the technique. Embolization has been described to decrease blood flow to the tumor as definitive treatment or to decrease the risk of major hemorrhage. However, this gives a risk of severe pain, fever, transaminitis, acidosis, recruitment from surrounding collaterals, and recanalization, whether performed as monotherapy or preoperatively, and the majority of these lesions will grow again. If given preoperatively, embolization results in severe pain and often fever and leukocytosis, with a need for post-procedure inpatient observation. Scheduling both interventional and radiology room time and operating room time is a challenge, and there is no consensus on the appropriate time interval between procedures, thus there's extended hospital costs and often increased length of stay. The goals of embolization are to control inflow to the tumor, to decompress or soften the lesion that allows access to the inflow and outflow that would otherwise be obscured. This is to decrease blood loss and the risk of major hemorrhage of resection and to enhance the safety of resection. The patient is placed on the operating room table in a hybrid OR suite that has intraoperative fluoroscopy and angiogram capabilities. A right femoral catheter is placed and on-table angiogram is performed of the SMA and celiac. This identifies inflow to the tumor, which is primarily from two major branches of the left hepatic artery. These are stepwise cannulated and embolized. The medial predominant branch of the left hepatic artery is selectively accessed and the first coil deployed with additional coil embolization performed. Angiogram reveals persistent arterial inflow from the left lateral branch, which was selectively cannulated and embolized in a similar fashion. After embolization, inflow to the tumor is significantly reduced. Under the same general anesthesia and on the same OR table, incision is performed and the hemangioma is exposed, replacing the entire left hepatic lobe. It is significantly decreased in size, though you can still see the sponginess with markedly delayed refilling. With the tumor smaller and able to be lifted and mobilized, now the porta hepatis can be approached with the finger through the foramen of Winslow as demonstrated. The hilar plate is carefully lowered. The left hepatic artery is skeletonized and ligated.
The left portal vein is now skeletonized. The right portal vein is carefully identified. The left portal vein encircled with the vessel loop and divided with the endo-GIA stapler. Attention is now turned to the hepatic outflow. The IVC is dissected, as is the left hepatic vein origin at the IVC identified on ultrasound. The left lobe is now rotated medially, and the left hepatic vein approached with dissection of the ductus venosus. The tumor is identified under ultrasound, and the course of the middle hepatic vein and edge of the tumor marked with electrocautery on the surface. The left hepatic vein is now divided with the endo-GIA stapler. With the inflow and outflow controlled, parenchymal dissection is initiated with a crush clamping technique. Dissection begins in the anatomical plane, but as the hemangioma abuts the middle hepatic vein here, it is enucleated, and small branches to the middle hepatic vein are sequentially ligated and divided. The preoperative embolization had enabled adequate control of the inflow to allow inflow ligation prior to the enucleation, which decreased risk in blood loss. Additional small hemangiomas are here demonstrated with the DeBakey forceps. The origin of the left hepatic vein is stapled flush with the inferior vena cava, and the middle hepatic vein demonstrated skeletonized from its origin on the IVC. Estimated blood loss for the procedure was approximately 150 milliliters. The patient was discharged free of her preoperative pain and symptoms on postoperative day 4. We conclude that combining on-table embolization with immediate resection avoids post-procedure pain and many of the pitfalls of preoperative embolization. It uses efficiently hospital resources and reduces an intervening hospital admission. We have found this to be a preferred approach to enhance the safety and feasibility of resection for massive hepatic hemangiomas.
Professor Ajay, very nice video. Fantastic. So I think a very important message that huge hemangiomas have to be dealt with a kind of hybrid approach with angiography, blockage of artery, and leading to surgery without any blood loss. It was an amazing job. So I would start the discussion by asking a single question. We had a case presentation before this session about hemangioma and liver transplantation in huge hemangiomas or benign tumors. So what is your take on when would you like to resect? Because there are certain hemangiomas which are asymptomatic, but some centers keep on waiting and waiting. My personal choice is if they are close to a porta or blood vessels, I would like to operate because they grow and then they obstruct. So what is your take on indications for surgery in hemangiomas, asymptomatic ones?
Sure. You know, I think the most important thing is if there's no evidence of Kasabach merit and the platelets are normal and the patient is asymptomatic, there is certainly no rush to go and plan that surgery at the first time you're meeting the patient. There has to be some observation of the natural history of how fast that particular hemangioma is growing. If you have a natural history of a rapidly expanding hemangioma in an otherwise young and healthy patient, then I think it's very reasonable to consider resection. But really, the driving force should be the symptoms. If you have an older patient that has no symptoms, and this has been found incidentally or minimal symptoms, you know, the mortality of resection for these in the literature, granted these are case series, but the mortality ranges from 3 to 15%. And so these are not completely safe, benign procedures in all hands across, you know, internationally. Of course, in experienced centers, there's going to be very safe handling of these. And what was demonstrated here was just one technique to try and make that a little bit safer. But to answer your question, I think in the absence of symptoms, you need a very good reason to be going in to resect these.
Nicely pointed out. Any other questions from the panel? House? Anybody? Well, if no, then I think let's proceed to the last talk of this session, robotic liver resection.
Thank you very much.
Thank you, Ajay. Thank you for this wonderful talk.
Yeah, I would like to, it's my great pleasure to invite Dr. Fabrizio Benedetto. He is a professor of surgery at University of Modena and Reggio Emilia. He's also director of HPB Surgery and Liver Transplant Unit. And he's also the General Surgery Residency Program Director at Modena, Italy. Welcome, Dr. Benedetto, for your talk. He will be talking about robotic liver resection.
And thank you, Ashish, for the invitation. Let's start saying the history of robotic surgery, liver surgery, is relatively recent with a fast growth. In the last 5 years, some important milestones have been reached as living donor hepatectomy and advanced liver resection. Pro and cons are well known, but most importantly, it has been demonstrated that oncological outcomes are comparable to open and laparoscopic approaches. After all those beautiful presentations, surgical oncology, I think it's more useful to jump the video to have a more precise idea of the potential of the robot. This is a 70-year-old patient with liver cirrhosis, already underwent multiple regional treatment, no clinical portal hypertension, scheduled for left hepatectomy, extended to segment 5. The CT scan showed the lesion about the hilum. We always start with the US to check the resection margins and to identify the vascular structure. As you know, this is the middle hepatic vein. We isolated the left hepatic artery and divided usually between Imoloc clip, sometimes with a stitch. And here you can see the management of small bleeding from the left portal vein. I want to highlight the agility and the comfort of the robot platform in this condition, thanks to image stability and instrument articulation. Moreover, it is important to have a good feeling with a tableside team to manage complex scenario like vascular clamping, like in this case. We also close the left hepatic vein with a stitch, left portal vein, sorry, with a stitch and Imoloc. And then we remove the bulldog. This is the left duct. In this case, we prepare outside the liver, and then we clip it and cut. The transection usually is conducted by harmonic case and bipolar forceps. For open surgery, we use always the CUSA, but the robotic setting, I think that the consult surgeon should drive the transection. To move to the left hepatic vein, we isolate it and suspend it on a tape and then stapled it. You will see later that in some cases, hepatic vein can be controlled with a clip according to size. This is the final specimen and the detail of tumor abutting the gallbladder. Finally, is the specimen, and finally the patient was discharged on post-operative day 3 in good condition. This another video. This is my first ALBS, robotic ALBS, totally robotic ALBS, in a young patient affected by ABV chronic infection, and he presented with a 7 centimeter of tumor with a portal thrombus in a branch of segment 8. Here you can see the 3D model. Future liver remnant is 19%. This is the trocar disposition. We started with ultrasound to confirm the vascular anatomy as usual. This is the middle hepatic vein, and then we mobilized the right lobe. And in this case, we didn't flip the liver to avoid tumor squeezing, given the large size of the mass and the presence of interhepatic tumor for segment 8. On the contrary, we completely isolated the vena cava, creating a sort of tunnel by dividing short hepatic vein, as you can see, between hemoloclip. This is possible thanks to the ability of the robot to safely work in narrow and deeper spaces. So this way, we extended the dissection to reach the confluence of right hepatic vein. At this point, we started with the transection that in this case was performed before approaching the hilum to gain easier access. We perform a classic ALBS. As you know, the Achilles heel of this procedure is the risk of the injury of the arterial supply for segment 4 that may result in parenchyma necrosis and subsequently biliary fistula. We pushed the transection plane with the Kelly crash technique to the middle hepatic vein cuff, as you can see here, with a complete parenchymal split. Is the middle hepatic, the isolation middle hepatic vein to prepare the second step, and this is a view of middle hepatic and caval vein. So we move to the hilum, and after cholecystectomy, the right hepatic artery is isolated first and suspended on a tape to have a better exposure of the portal vein. We usually completely isolated portal bifurcation to have a safe control of the right portal branch, which is prepared, as you can see, and suspended on a tape, and then divided between hemlock clip in this case or stapler. I always aim to reproduce the same moves of open surgery thanks to the dexterity of robotic instruments. At this point, we apply the taco seal on the vena cava and on the transection plane, and we left in place 2 drains. This is the final aspect of the patient, abdominal wall. Postoperative course was uneventful, and on postoperative day 8, future liver remnant is up to 37%, as you can see in the CT scan, and postoperative 10, we scheduled the second step. This is the 3 model, and we use the same trocar access, and we found few adhesions and no collection entering with the camera in the abdomen. The vena cava and the hilum were completely free and accessible, probably thanks to the short interstage interval. We applied the bulldog on the right hepatic artery and checked the left flow, artery, portal, and hepatic flow. and then we divided it. As you can see, the vision is more stable. Immediately after, we move to the right duct, as you can see, and close it in the same way. Then to move to the transection plane, where we found the middle hepatic vein, already isolated and divided it. And we move to the right hepatic vein, and we complete the Kelly crush around the right hepatic vein, which was prepared. And circle and suspended on a tape. Sometimes we use a chest tube to have the access of the right hepatic vein, and then stapler with a 35 millimeter vascular endo GIA. I think that advanced of performing an AILBS with robotic techniques are reduce the interstage complication and increase the rate of second stage completion. This is the final aspect of the left. This is the spacement and the final aspect of the abdominal wall. The postoperative was an eventful and the patient was discharged on postoperative 3. In conclusion, I think that robotic liver resection can be safely performed with good outcomes without restrictions when a formal learning curve is completed, and we can reproduce the same procedure with the same result in open surgery. Thank you very much.
Thank you, Fabrizio, for the excellent presentation. The floor is now open to questions.
So, Dr. Fabrizio, it was a very nice presentation and compliments for doing such complex procedure by minimal access route. And I think so it's the videos are quite self-explanatory, and it really suggests the difficulty of the case, but done so well with your good technique and good understanding of the technology and the perfect skills. So if there are no more questions.
Fabrizio, excellent talk, Ashish this side. What do you take? Is there any contraindication for to get from the get-go for the robotic major hepatectomy, or and what's your experience? If any, what is the reason for conversion? If you have any in your experience.
Thank you for a good question. I think that in my center, the contraindication for major hepatectomy with robot approach is major vascular resection or involvement in preoperative workup. And we have a good experience with the redo surgery, and in particular in patient listed for liver transplant, in patient with ACC listed for liver transplant. And when we have large tumor, sometimes the robotic approach is difficult. We have some difficulty to move inside the abdomen for huge ACC, for example. But usually in my center, 60% of liver resection we perform with the robot approach.
Okay. Any questions from the chairpersons or the other speakers? All right. If you don't have it, then we can close the session. Thank you all the speakers and chairpersons for joining us today, and have a good weekend. Thank you.
Good night to all.
Thank you very much. Thank you very much for the invitation. Bye-bye.
Bye. Thank you.
Bye.
Thank you.
Thank you very much. Bye.
So we are done with today, and hope to see you all from tomorrow. Just to share that we have been joined by around more than 400 delegates across the world for today's session at different time points. And I would like to thank LTSI for their support and their participation in this meeting, and we'll see you soon tomorrow. Thank you.